what are the indications for this?
Buenos días. Vamos a comenzar la puntualidad. No sé si el público va.
Good morning. We're going to start our session on time. I don't know if people will make it to, because we have a lot of people joining us. We will begin the first session in the morning. This is a completely tragic session. First of all, because of the time, and secondly, because none of the two chairmen are present. I'm acting on their behalf. The good thing is that Dan Canny is the superstar. There is a person called Nestor Zurita who's going to have an intervention, and then lastly Emilio Carbo, who will participate virtually. And he has two simultaneous sessions. So first of all, we're going to have Jen Kenny, who will speak about the rational indications on tendon transfer. And then then will continue with the latissimus dorsi transfer. Well, thank you. I'm the superstar today. The first slide.
May I have the laser, please? Next slide. So we're going to talk about the rational indication of tendon transfer. Next slide, please. I have no conflict of interest regarding that. Next, please. Siguiente. Muchas gracias. So first of all, I would like to talk about the words, because I think sometimes we are talking something different. So when you see this video, you can see that massive means massive cuff tear means no tendon. So when you have no tendon, you cannot repair. You can see here this video, there is no tendon, only muscle. Of course, you will not be able to repair this joint. But sometimes, like in this situation, you have a very large tear, a big rupture. You can see here this massive cuff tear, so co-filled more than 5 centimeters, Gerber more than 2 tendons. You have a deep layer, but finally, at the end, you see this deep layer. Finally, at the end, it will be possible to repair everything. So massive cuff tear is totally different than irreparable cuff tear, and we have to take it on account if you're able to repair the deep layer. So what is irreparable? Irreparable before the surgery, you can anticipate that, and before the surgery, you can know that you have atrophy of a muscle bellies. You may have also, but this is not the main important factor. The main important factor probably is the fat infiltration, grade 3 or 4 of the muscle bellies. And of course, the superior migration, the superior escape of the humeral head less than 6 millimeters. That means, if you follow Jill Walsh, that there is an extension of the tear beyond the teres minor, and this is probably a very, very bad prognostic factor. So this is a French study regarding general risk factor, and it is very important to understand and to know that you see the smoke, cholesterol, hypertension, diabetes, obesity, cardiovascular or apnea. More than 5 risk factors for one patient means the risk of return of 100%. So I repeat, more than 5 risk factors means 100% of return. So probably it's totally useless to try to repair such a patient. And the last point, you're not better than your friend. And when your patient have been operated on previously, I am sure that you will not be able to make better than your friend. And this is, for me, a very, very bad risk factor. So before the surgery, you can know whether you will be able or not to repair your cuff. So I think don't try to repair again. So now the question is, what is a theoretic shoulder? And when you travel with American guys, we don't have the same definition. So Burks, in this paper, which is in 2017, remind us what is for him a pseudopelvic shoulder, active elevation less than 45 degrees on the video on the left. But you can see on the right side, it is not a pseudopelvic shoulder. The patient is able to elevate the shoulder, and there is lots of pain, and because of the pain, she is not able to have a full range of motion. The second situation is not a pseudopelvic shoulder. So for us, a pseudopelvic shoulder is lack of elevation active less than 45 degrees. So now, surprisingly, some massive cuff tear do not need any repair. Look at this guy who is very strong without any pain, but look at his X-ray, look at his MRI, there is no pain. So this patient does not need anything, in fact, and massive does not mean pseudopelvic, of course. And now the question, if you follow the idea of Pascal Boileau, the idea is you have 2 types of patients with the same X-ray. This patient has normal range of motion with elevation and even in rotation, and the other one has a non-functional shoulder with total loss of range of motion active. So the same X-ray, the same anatomical lesion, but 2 different patients. And the question is why a functional shoulder may turn to a non-functional shoulder. And we're going to try to understand that. So before pushing on, if you go back in this paper in 1988, the shoulder biomechanic, you can remember that you have the starters of a shoulder with the deltoid, the pec major, and the clavicle head, clavicle portion of the pec major on one side, and you have on the other side the stabilizers of the shoulder with the supraspinatus, the infraspinatus, and the subscap. So knowing that, it is very important to understand this paper of Jean-David Vertel and Bassem El Hassan, very recent paper. When you have no deltoid but a good curve, you will have a normal active range of motion because your joint is stable enough and range of motion is made by your cuff. Your cuff is healthy. In that situation, do not do any treatment because no treatment is needed because your patient has a normal range of motion. So maybe he has lack of power, but he does not need anything. On the other point, when you have no cuff, but a good deltoid, this is totally different. This situation may lead, it's not always a rule, but may lead to loss of active range of motion in one or in two directions. And it can bring an unstable shoulder with a superior escape. So in that situation, of course, you can propose a dynamic transfer, but you have to stabilize your shoulder first. So if you have an unstable shoulder, it is totally useless to try to propose a dynamic transfer. So first of all, stabilize your shoulder. Second, you can propose a dynamic transfer. So now what happens if you have a posterior and superior escape of a shoulder? No supra, no infra, and no teres minor. You may have, it's not a rule, but you may have a posterior and superior escape in 33% of your patient of your shoulder of pseudoparalysis, 33. This is a paper of Philippe Collin. And on another side, if you have no subscap and no supraspinatus, you have 80% of having a pseudoparalytic shoulder, 80%. So the anterior and superior lesions are more aggressive regarding the function of your shoulder than the posterior superior one. So look at now this balance. Look at this balance. You have two children on a balance and the distance is different. My question is, what is the weight of the first one to balance with the weight of the second one, depending on the length? And it is a mathematic rule. L1P1 means L2P2, so it's very easy. All the children of 14 years old know this rule. So what happened in the shoulder? What happened in the shoulder? Look at the center of rotation of the human head is in the head, of course. So you have 3 centimeters versus 30 centimeters. So that means if you follow this rule, if you want to elevate your arm with a weight of 1 kilo, you have to counterbalance 10 kilos. And this is only for the elbow. Imagine if you want to lift up a bottle of water at the end of your arm. So our purpose today is to go beyond the tendon transfer and to talk about the tendon transfer, but I would like to talk a little about the spacer and the balloons to try to understand what are the limits, the partial repair, biceps tenotomy, the superior capsular reconstruction, and of course, the reverse plus or minus tendon transfer. I don't have any option or solution today. We need all the day to discuss about that, but I would like just to draw you my lines. So when the very beginning of the tendon transfer began, of course, everybody knows Christian Gerber, who imagined in 1988 this the latissimus dorsi transfer. But in fact, remember and try to understand that Gerber did not imagine the lat dorsi. He just copied the Hofer procedure, which was an American procedure made for brachial plexus obstetrical palsy. And he learned this technique with Gilbert in France, in Paris in 1984. And he just reproduced that in the adult because he realized that the same position of the children gave it was the same clinical apparently problem. But pediatric is not adult, and supraspinatic is not stiff shoulder. But now, what about our patient algorithm? So this is what Pascal Boileau have called the painful loss of elevation active. You remember this patient, it is not a stereotypic shoulder. She has lack of elevation, but because of pain, she can help herself, but you can understand very easily, if you cut the pain, then the patient will be happy. In that situation, what could you propose? A partial repair? Yes, of course. And I think you should propose that first. Cut the biceps and do your partial repair. But what's next if you have a failure? The question is, what's next if you have a failure? So a balloon, look at this balloon after 1 month on my furniture. This balloon does not exist after 1 month. So how can it work after 2 or 3 years in the body? Because biomechanically it's bioreabsorbable and maybe it cut the pain for a few weeks, but how can it work with a long-term follow-up? I cannot believe in that technique in the long-term way. What about the superior capsular reconstruction? Of course, it's a very good idea, but remember that this will just stabilize the shoulder. It is not a dynamic transfer. So you can stabilize your shoulder, you can help your shoulder, but you cannot create, you cannot fire the muscles. And the reverse is the last option, of course, but what do you propose when the patient is very young, 50, 55 years old? So for me, this clear, painful loss of elevation active, it is for me the best indication of a latissimus dorsi transfer. Type D of Philip Collin, when you have no supra, no infra, you do the Hofer procedure and you can make it with a full arthroscopic procedure. So number two, described by Pascal Boileau, again, the posterior chair, so isolated loss of external rotation active. You see this patient has no pain, he can elevate his shoulder, but he has no external rotation, he has a Hornbrough sign. This is an extension to the supra, infra, and teres minor, and with the same idea, a partial repair, yes, but the problem, you will repair something with a fat infiltration with more than stage 3, and how can it work? Because you can repair the tendon, but you have no muscle. So a balloon, you know what I think about the balloon. This is the balloon after 1 month. And SCR, but if you do an SCR, where will you go to fix it posteriorly? Because a good SCR works when you fix onto the glenoid, onto the anterior and posterior part of the border of the tendon, and onto the humerus. So this can work. But you have nothing behind. Where will you go? You have no teres minor. You cannot fix your posteriorly your SCR. I think this is a limit of the SCR, and it's not really clear when you read the American papers. And again, when you can propose a reverse, but a reverse cannot recreate the external active rotation. A reverse can elevate your shoulder, but it cannot recreate external rotation. So you have to plan for reverse maybe, plus lat dorsi, episcopo. But in that situation, the tendon transfer works very well. And in that situation, type E of Philip Collin, supra, infra, and teres minor, the best transfer is the one described by Bassem El Hassan. It is the lower trapezius transfer. The lower trapezius transfer is efficient to external rotate arm onto the shoulder. And the last situation is the deficit of elevation, internal rotation, the ILIR. I described it a few years ago. It's the isolated loss of internal rotation active. And in the same, you can make a partial repair, but if you have a fat infiltration of your subscap, how can it work? The balloon, you know what I think. The SCR, yes, but where will you fix the SCR? Because you have no subscap, you have no subscap. So it's not possible to use the SCR in that situation. For me, the SCR is for isolated supra, maybe infra, but not for when you have no subscap. And it's not when you have no infraspinatus teres minor. So yes, you can put a reverse, but the reverse cannot recreate rotation. So you have a limit because you have to stabilize your shoulder first and then to put a dynamic transfer. So the lat dorsi is efficient to internal rotate, and it is the paper we wrote with Bassem El Hassan. You can make an anterior transfer of the latissimus dorsi transfer. So now if you go to the pseudopelvic shoulder, you can see the eyelid described by Pascal Boileau again. So you have a vertical imbalance of the shoulder. The only way is the reverse. You have to medialize the center of rotation of your head. So it's a biomechanic concept. And because of your medialization, you increase and you improve the lever arm of the deltoid, and it can work. So you have no option to elevate the shoulder instead of medialization of the center of rotation. And in the same way, this is a draw of Pascal Boileau again, and the same is when you have both vertical, horizontal and vertical imbalance of the shoulder. Then if you just put a prosthesis, you will have no rotation. The price to pay is elevation but no rotation, and then you have to do the combine reverse plus latissimus dorsi. We call this the clear and the reverse combined with the Nice Episcopo procedure. And in the same way, when you have a combined loss of elevation and internal rotation, the only way is to make a reverse plus or minus is not clear, a tendon transfer with a pec major transfer. So now, in conclusion, how to get it better? My next way now is to make a lat dorsi arthroscopic full procedure plus a superior capsular reconstruction with a biceps, if the biceps is still present, because the biceps is already fixed onto the glenoid, and then it's very easy to fix the biceps onto the upper part of the footprint of a supra of a greater tuberosity. So lat dorsi to restore active range of motion plus SCR to stabilize the shoulder. So remember, first you stabilize, second you create a dynamic transfer. This is the rule. So in conclusion, when you have only one direction of deficiency, lack of elevation, or lack of external rotation, or lack of internal rotation, but your shoulder is stable, so you have just lack in one direction, this is the way and the field and the target of a tendon transfer, isolated or augmented with a superior capsular reconstruction with a biceps. Second point, when you have a pseudopelvic shoulder, that means when your shoulder is unstable. So you have an eyelid described by Pascal, isolated of elevation. You have a clear combined loss of external rotation and elevation, and you have the clear combined loss of internal rotation and elevation. In that situation, you have first to stabilize your shoulder with a reverse, even if you have no arthritis, and you have to augment it with a tendon transfer if you think it could be better for rotation. Thank you very much, and welcome for the next Lemon shoulder. Sorry, a little time up here.
Thank you, Jean. Wonderful presentation. You can continue with the next one. All the morning if you want.
Okay, 15 minutes again, so I will try to stay in time. Okay. The second presentation, siguiente, por favor. So maybe you know this presentation, I've tried to modify something. So the idea is to make a latissimus dorsi transfer for the anterior superior cuff tear. So when to consider the subscapularis is irreparable. So this is an example. We've already discussed about that. So there is no arthritis, 65 years old, already operated with return of a supra, return of a subscap, and fatty infiltration. Don't try to repair it again. You will have a failure. So for me, this clear before the surgery, you know that your subscap will be irreparable. And as you remember, it is the type B of Philip Collin, and you have to worry about this lesion. You have to treat your patient, because if you wait, you may have a pseudopelvic shoulder in 80% of the cases. And remember that when you have a pseudopelvic shoulder, the result is you have to make a reverse shoulder prosthesis. And I think it's not a good idea. It's not a good idea. You can prevent it if you treat your patient before the superior escape. And this is the clear combined loss of elevation and internal rotation. For me, this is the true cerebroparetic shoulder because there are two different directions of deficit, lack of elevation and lack of internal rotation. So I've described this clear. And for me, you have an anterior and superior escape of a shoulder. When it is dynamic, maybe you can propose a lat dorsi, but I think it's too late. When it's static, so already when you see a patient, your shoulder is anterior, so it's too late, I think, except the reverse. In that situation, except the reverse plus or minus a tendon transfer, your tendon transfer cannot work alone. So let's go back to the isolated deficient subscapularis, the ILIR, isolated loss of internal rotation. You see this patient have a good elevation, have some pain, but you have no internal rotation. In that situation, if you have a failed previous repair subscap, because I think first of all, you have to try to repair this subscap, you have three options. When you have an isolated deficit of internal rotation, you can transfer the pec major, you can transfer the pec minor, sorry, you can transfer the pec major, or you can transfer the lat dorsi plus or minus the teres major. So let's go for the option number one, the pec minor transfer, described by Michael Wirth in 1997, and after described by Palladini and by Valenti with an arthroscopic control technique. I think, and I'm not the only one to thinking that, the tendon is very short, difficult to reach the greater tuberosity. It's weak, and there is a problem of line of pull because, again, either with the pec major, the same condition with pec major, if you want to have a good line of pull of the traction of your pec minor, you have to go under or behind the conjoint tendon. You create a U-shape turn of 180 degrees, and I think you cannot have a very nice or long excursion. So it could work for the upper part of a subscap tear, but I think it cannot work when you have a massive subscap tear, when you have a real ILI, isolated loss of internal rotation. So this is the option two. So probably you know this draw, this biomechanic. The problem of a pec major, like exactly for the pec minor, pec major, if you want to reproduce the line of pull of a subscap, you have to go behind the conjoint tendon. Again, you will create a lack of excursion, and probably if you look for a dynamic transfer, it's not the best one. It could work because we know the good result of Resch. We are going to see that. It could work because it's a pain cutter, but it cannot give a very good active internal rotation. So the last option is the way I've decided to follow with Bassem. Together, we've published some paper now, and the lat dorsi seems to be the best one to mimic the subscap biomechanically. It's very nice, and you can make it with an arthroscopic procedure. So Bassem imagined the biomechanic study, and I published the first clinical results. And I do now not only the lat dorsi transfer, but I combine the anterior lat dorsi transfer plus the anterior teres major transfer, even if Bassem said that you have a risk with axial nerve. In fact, it's dependent on the position of your distal fixation. But if you want to go over the head, maybe it's risky. But if you just put your double transfer onto the anterior part of the footprint of the subscap of the teres, lesser tuberosities, there is no risk of having a problem with axial nerve. You can see this is the paper of Bassem. Yes, the lat dorsi can mimic the subscap, but if you can pull it very high, but if you want to take the teres major, you don't have to go over the top. You have to stay in the anterior part of the footprint of the lower trapezius. So this is the full arthroscopic procedure. Oh, it's not a very long movie clip, but it's very easy to make it. I would like to say it's easier than a massive subscap tear. If you know how to make a massive subscap tear, you know how to make a latissimus dorsi transfer, especially anteriorly, because you make a dissection through healthy soft tissue. It's when you open the cadaver lab, you can make the dissection with your finger in 5 minutes, less than 5 minutes. So the only difference is you are under arthroscopic control. You just have to see where you are. But on the opposite, when you try to understand what is the coma sign, how to release the brachial plexus, to pass your suture through the subscap, which is very short, I can guarantee you that the full arthroscopic procedure is easier than the subscap repair intention. Here I'm separating the lat dorsi on the right from the teres major, because at this time I wanted to do only the lat dorsi, isolated lat dorsi transfer, but now I realize that it's easier to make both together, the double transfer of the lat dorsi plus teres major transfer. So let's go on. So in words of discussion, but everything is open. The goal of the surgery is to have a pain-free shoulder first, number one. And because of a pain-free shoulder, probably you can restore active interrotation, either because you just cut the pain or because you put a dynamic transfer, which help the range of motion. This is my first patient 15 years ago. And you can see at this time it was an open procedure, and you can see the active elevation, perfect. There is no superior and anterior escape of the shoulder, and you can see that there is no belly press test positive. So this patient is very happy. So of course, this lat dorsi had been published by 2 different teams. This is from Korea, my friend Beck, who published open procedure of the anterior latissimus dorsi transfer, and you can see the results here. And we published with Bassem and Jean Cagny, we publish a full arthroscopic procedure, and we've compared the open one and the full arthroscopic procedure. And you can see that the result, even if there are no wonderful, because we have some failure and everything is explained in this paper. So we have some failure, of course, and we just explain the limit of the indication, the indications, and the contraindication of this technique. But we have published a web paper. Regarding the pec major transfer, this is the result, and you can see that they are not so bad. So today, we can consider that this is the long-term evolution of pec major transfer. We have some papers too, and we cannot consider that it's a bad technique. I will never say the pec major is a bad technique. The pec major, as you can see, with long-term follow-up, even surprisingly augments internal rotation, surprisingly. And so it works, but I think this cut the pain and help the patient. So today, I think the pec major transfer is still the gold standard of the subscap deficiency, even if for the last 5 or 6 years, I've turned to the lat dorsi transfer for different results, because you can make it full arthroscopically and it's more logical. And I'm sure with time, we will prove that we have better results than the pec major. But the lat dorsi needs proof with time. And today, I cannot say the lat dorsi is the way. I have to confess that the pec major gives good result and the surgery maybe is more easy. Thank you very much.
Thank you very much, John. You can take some water before your next talk. A continuación, el doctor Néstor Zurita nos habla de la transferencia del pectoral mayor para el desgarro del subescapular.
Hola, buenos días a todos. Mientras
Hello,
solucionamos.
good morning, everybody. While we solve a few technical issues, I would like to thank Dr. Kani for how easy he has made things for me, because after his words, there is little more to add. So I won't finish too late, and we can go and have some coffee soon.
No sé si habrá que entrar otra vez. Ahora. Bueno, pues como he dicho antes, bienvenidos a todos a esta hora.
As I said before, welcome to this hour on a Friday. I'm going to try to share my experiences after this keynote speech and lecture by Dr. Keeney. I'm going to try to look at all the different aspects of the results of the irreparable lesions of the subscapularis. I work in School, which is a trauma service that is part of or that Dr. Angel Calvo is the founder of, and we work there as well. We have always spoken about the importance of the subscapularis. We have always shared the idea that any lesion or any surgery performed with a complete subscapularis tends to go well, and all surgery where there is a subscapularis with significant lesions tend to not go well. So this is an important part of the rotator cuff. Because, I mean, there can also be supraspinatus issues, so there may be lesions in the head, and this may lead to a pseudo-paralytic shoulder, which could be the worst scenario for a shoulder. And although lesions are not very frequent, the consequences can be very severe. Therefore, the classic option to date has always been the transfer of the pec major. In principle, this tendon allows for flexion and internal rotation of the humerus, and from this point of view may share the functions of the subscapularis. Despite this, it does not replicate the vector of strength of the subscapularis because it is posterior to the thoracic wall, and this will obviously have its consequences. How do we perform the transfer of the pec major? Usually with a specific and general method. We use the beach chair position. We go towards the minor tuberosity to cover the deficit left by the subscapularis going from the humeral shaft. And let's say that the tendon is anterior to the conjoint tendon. Normally, as a result, patients are pretty happy because they have good functionality and they feel satisfied, but they do not recover the same strength in internal or external rotation. In this context, a number of modifications are made over time. And the first thing that you do is take much more of the tendon, maybe the whole pec, to cover the anterior superior part where there are lesions of the supraspinatus often. And here the results are that patients feel satisfied, but we still have the same problem as before. So there's a reduction in their strength. They do not fully recover and recover that strength, and they may have the same situation they had before surgery. Following this line, instead of transferring the external part, so the most frequent part, we can transfer the clavicular part. And here, instead of putting it anterior to the conjoined tendon, it can be passed through the back. Once this has been done, we suture the rest of the rotator cuff to try to cover the whole humeral head. After this technique, mobility doesn't improve in comparison to before the surgery, and although pain improves, we still have the same levels of strength. And therefore, the authors that describe the modification of this technique conclude that the tangent of the pectoral major in this, or the transfer of the pectoral major, would not be indicated for the tear of both tendons in a combined manner. Finally, this new option where we take the external part as part of the tendon to perform the transfer. This time we leave it posterior to the conjoined tendon, and the idea is to improve the strength vector, so it's similar to the subscapularis. So it's still the same, the force vector. So there's improvement in the pain and the functional scales as well, but there are no improvements in mobility or strength. Therefore, the transfer of the latissimus dorsi would be more recommended for people with low demand. And in this context, as Dr. Candy said, there is an option to perform the transfer instead with the latissimus dorsi instead of the pec major. It seems that the vector of force, or the force vector, is much higher than the subscapularis. And although the bibliography is limited, the literature is limited, it does give you good, it is pretty satisfactory in the little literature we already have. It seems Dr. Canny does it very easily, but it's not actually that easy. And this, in fact, may be one of the limitations of this technique, because we may, there may be a lesion produced. Therefore, and at present, the classic option for the transfer of the entire tendon or part of the tendon of the pec major is the option for non or irreparable subscapularis lesions. The results are pretty satisfactory in terms of the patient satisfaction, because the pain improves, and also the functional improvement that it leads to. It's true that they cannot maintain or recover their strength or mobility, and therefore it's indicated for people with low demand above all, and with the alternative through use of the latissimus dorsi. I'd like to thank you all for listening and for being here. Thank you. Thank you, Nestor. I think, well, thank you also for keeping it short. And thank you for Dr. Canny for telling us about latissimus dorsi and posterior inferior lesions.
Maybe it was not clear in my presentation. I don't want to say the lat dorsi is easy. I just wanted to say that the lat dorsi is easier than a subscap repair. Because you have a lot of anatomic adhesion, fibrosis, and this is very difficult. So I think the lat dorsi is easier subscap repair. This is just what I wanted to say. So let's go to the posterior superior cuff tear in the same way. So I have, of course, no conflict of interest for that situation. But when to consider a posterior superior cuff irreparable. So you remember this picture, we have to look at the atrophy of a muscle belly. And this is before the surgery, but this is not for me the main important factors. The main important factors, because it's resolutive, it is reversible, but the fat infiltration is not reversible, and the superior migration of the human head is not reversible. So the cases, so it's not as much as for the anterior superior escape, but the fact is you may have, it's not always a rule, but you may have a superior escape of a shoulder, posterior and superior escape. So what may happen when no posterior superior cuff? What may happen? So you have possible of having a total loss of elevation active, is totally different, but all these situations may arrive because you have a posterior and superior cuff irreparable. In that second situation, there is no pseudopathic shoulder, so it's totally different. So Pascal, again, I've described this a long time ago. You have no elevation, but you have a good external rotation. This is the isolated loss of elevation. Yes, of course, only one direction, but there is a vertical total imbalance of against the weight. Because there is, with a tendon transfer, if you do not modify the center of rotation. This is the clear described by Pascal, combined loss of elevation and external rotation. So there is no active elevation, but loss of external active rotation and loss of active ER2. So there is both a horizontal imbalance of the shoulder because there is no posterior and superior cuff. And in that situation, it is a cervical shoulder. This is the combined reverse plus episcopal, because if you only do a reverse, you will have no external rotation and the patient will not be able to do only a transfer. The patient will not have elevation and the patient will be unhappy too. So you have to treat both together, and even if there is no arthritis, this is the only way. So now it is totally different. It is also the same lesion. You have no superior and posterior cuff. The patient has a Hornbrough sign. There is most of the time no pain. The subscap is too strong and there is no infraspinatus. This is the isolated loss of external rotation. So the patient is able to elevate, but unable to have. In that situations, three options are possible. The number one is the lower trapezius. The second one is the teres major transfer. And the last one, of course, is the lat dorsi transfer. When you have no infra and no teres minor, these are the three options you have when you have no pseudopelvic shoulder, when you have no pseudopelvic shoulder. So when you have isolated loss of external rotation. So I advise you to read again this paper written by Hausler and Bassem El Hassan. And you can see that the best tendon transfer to reach one when the elbow is at the body is the lower trapezius. The lower arm side is much more better than the lat dorsi. This is the reason why American friends prefer the lower trapezius, and I follow them in that indication, in this indication. But this indication for me is very rare, less than 5% a year for me. On the opposite, when you have a painful loss of elevation active, you only have a vertical imbalance of the shoulder, you just have to cut the pain. So where does it come from the pain? I don't know, but the patient has some pain, and this woman have been already operated on 3 times of her shoulder and still have some pain. So for me, the problem is the disbalance of the shoulder. Probably the posterior cuff, the remnant posterior cuff is not strong enough. The subscap is too strong. The remnant teres minor is not strong, and the physio is not able to restore a good balance of the shoulder. I do this posterior transfer just to augment the posterior remnant cuff, just to rebalance with the subscap. For me, this indication is just to physio. Before taking such a decision, you have to try partial repair, bicep tenodesis, then physio, of course, and in case physio can treat this patient if you listen Philippe Collin. But sometimes, after 1 or 2 years of physio, the posterior cuff is too weak. Then you do your lat dorsi. You just rebalance the shoulder and it works. So, of course, this is again the offer procedure. And I make it with a full arthroscopic procedure. So for me, it's a 1-day surgery. The surgery less than 60 minutes. So it's not invasive. I want to say it's not an invasive surgery. But you have to train and to learn, of course. I don't say there is no risk at all, but you can learn. It is really minimally invasive. It's not like prosthesis, and you do not cut any bridges. So the Hofer procedure for me, arthroscopic Hofer procedure, is my indications. It is a combined latissimus dorsi plus teres major for posterior superior cuff tear, and here are my preliminary results out of more than 100 patients. So since January 2018, I've started this technique, this full arthroscopic procedure for the PLEA, you understand, painful loss of lower trapezius is better if you want to restore external rotation. So what are my complications? So look at on the first column, you have the full arthroscopic combined procedure. And on the right column, you have the arthroscopic assisted mini open technique. So the risk of having hematoma and infection does not exist with the arthroscopic technique. But you have a lot of such a problem because the axillary field is not very clean, in fact, and you may have some hematoma and infection, of course, and this is not very good for the future. On the opposite, yes, you have your learning curve, and I had some nerve problems, 3 for the axial nerve because it's very close to the tendon, and 1 for radial nerve because it's very close to the tendon, but only transitory, and I didn't have such a problem for the last 2 years now. So finally, look at the number of early revisions, either drainage or reverse. You can see with the lat dorsi, with a full arthroscopic procedure, I can say I have no revisions, but I have much more revisions with the open technique. But there is a bias because, of course, the follow-up is not exactly the same. I have a longer follow-up with the open technique, and we can understand that I have more shoulder revision than with arthroscopic technique. So we have to take care about this conclusion. But just to show that finally, with a full arthroscopic procedure, I have 9% of complications, and I have 22% of complication with open surgery. So you remember this picture. Now, how can I get it better? First, you stabilize. Second, you transfer. So to stabilize, if the biceps is still there, because sometimes it's not there, if the biceps is still there, I use the biceps to make a superior capsular biologic reconstruction. Plus, I augment it with a tendon transfer, the lat dorsi, to restore active motion. So it is exactly the same conclusion, but I think teaching is repeating. The player, type D, the Eiler, isolated loss of external rotation, and the isolated loss of internal rotation. In these 3 different patterns, you can propose an isolated tendon transfer. Augment it, if possible, with the biceps. On the opposite, always the same. When you have a pseudopec shoulder, that means when your shoulder is unstable, either static or dynamic, of course, these are the 3 different patterns, and with the anatomic correspondence, the highly, the clear of the clear, there is a mistake. Sorry, the last, it's a very I instead of a E. So in that 3 situations, it is the reverse. First, the reverse, and then maybe you can put the transfer if you want, but it's a reverse in that situation. Don't try to do an isolated transfer. It will be a failure. Thank you very much, my friend.
Thank you, Yang. You can take a rest for a few minutes. Ahora vamos a poner una presentación grabada del doctor Emilio Calvo, que
Now we're
está
going to watch a recorded presentation from Dr. Emilio Calvo, who is in room 3 because it coincided with his presentation there. So we will now watch his presentation.
Va solo, pero va a fijar. En el Barahona 3, él inicia a las 8:15, a las, perdón, a las 8:18, ya casi va a empezar.
Claro, se pone su presentación.
Pero todavía no, ahorita vino ya la chica diciendo que allá no hay ningún.
Dear Chairman, dear friends, it's a real pleasure to share with you this scientific session chaired by Eska on irreparable rotator cuff tears, and I will approach the topic of lower trapezius transfer for irreparable posterior superior rotator cuff tears. This is the problem we have. There are currently patients with a massive irreparable rotator cuff tear with important fatty atrophy who have a clear lag sign and a hornblower showing the important failure of supraspinatus and infraspinatus. So for this patient, there's no possibility to do a repair, and we should think in other alternatives. Since they are young enough, probably tendon transfer is a good alternative for them. But regarding tendon transfer, the most common procedure used is latissimus dorsi transfer. There are several reports in the literature that demonstrate that latissimus dorsi transfer is a good option for patients with irreparable posterior superior rotator cuff tear. However, in the recent situation, it's been suggested to use the lower trapezius instead of lower latissimus dorsi to restore the force for abduction and external rotation. And there is a clear rationale for this. The line of pull of lower trapezius is similar to that of infraspinatus. The excursion and tension force is also similar to infraspinatus, and the muscle fires during rotator cuff elevation, making much easier the retraining after surgery. What are the indications for these patients? We should think about this procedure for young, active patients with no or minimal shoulder arthritis, with a clear, limited function or painful elevation and irreparable posterior superior rotator cuff tear. It's very important to confirm that the patient have a external rotation lag or at least weakness, and there's a clear, irreparable infraspinatus tear with fatty infiltration. Concerning contraindications, there's absolute contraindication like the presence of infection, trapezius palsy, and relative indications are humeral arthritis and suprascapularis insufficiency. With regard to surgical technique, this is the lower trapezius that are inserted on the spine of the scapula. We define several portals, posterior, anterolateral, and anterior, to deal with the allograft. You can see here the direction of the tendon, and here we can, after this vertical incision, we can find the lower trapezius. Here is the axilla of the muscle that is very efficient to identify the most inferior border of the lower trapezius. This is my superior border, and after defining the limits of the lower trapezius, we can start dissecting the tissue to obtain the lower trapezius flap to start with the transfer. Here we have the lower trapezius. This is the superior border. This is the excursion, and we can put 2 stitches in a crack-on fashion to reconstruct the posterior superior forescapula. This is our particular view. This is a clear posterior superior irreparable direct of tear with some remains of the spinatus and teres minor. This is the direction that the allograft will. And the first step is to create a window through the fascia of the spinatus, and through this window, the graft will be passed to the interior of the humeral joint. Here we can see the allograft. As you can see, we use a Achilles allograft. 2 stitches in a crack-on fashion are on the vertex of this graft, and they are used to pull the graft into the joint, bringing it till the superior surface of the greater tuberosity. This is the excursion of the allograft. There's usually enough tendon to reattach or to connect this allograft to the original lower trapezius. So the first step should be to attach this allograft on the great tuberosity. So we separate both limbs of the suture that were used to bring it into the joint. This is my anterior medial. And the first anchor and the first part of the allograft to be fixed to the great tuberosity is the posterior medial, because it's the time to do it just to obtain a good visualization of this part of the allograft. So using any kind of suture passer, suture are passed through the allograft, and once they are past the tendon, the donor tendon can be attached to the posterior medial part of the great tuberosity. Secondly, we proceed with the fixation of the anterior medial attachment. I prefer for this purpose to use these self-punching anchors. Same with the anterolateral anchor. So in this way, we'll have the entire edge of the tendon attached. And finally, we will fix the posterolateral anchor, trying to attach the most posterolateral aspect of the allograft to the greater tuberosity. You see here how the posterolateral edge is attached to the posterolateral area of the footprint. And now we can test the stability of this graft. And once we make sure that it's stable, we proceed to connect the medial part of the allograft to the lower trapezius. It's important to make sure that the allograft moves freely with rotations, and this is the final aspect. The graft is connected to the lower trapezius, as you can see here. 6 weeks of brace with a pillow, and then physical therapy started. This is my post-operative protocol, and there are several communications on the results of the technique in the literature. As you can see here, there are many by the author of the technique, who is Bassam Al Hassan, but also there are reports from other authors that have demonstrated the utility of this technique. So finally, we can conclude that the lower trapezius transfer is a good alternative for patients with irreparable posterior superior rotator cuff tear. Thank you very much.
Muchas gracias. Por favor, doctor Cani, Néstor.
Dr. Kenny and Nestor, I think that there is an opportunity today, almost a unique opportunity, to have one of the most important European experts in stand the transfers, and I would like you to benefit from this and to gather all the information you need from this expert.
Morning. For Dr. Kenny, recently you have published a paper with Laurent Pascal and Philippe Valenti, and where you compare the results of LTT transfer with arthroscopic partial repair in patients with are that very interesting. Your approach in this kind of patient with painful loss of active elevation and type D colon lesions, or did not?
Okay, thank you for your question. In fact, with Jean-David Vertel, but I was not a co-author, and Pascal and Laurent were not co-author too. But I think it's the same. I think you talk, Philippe is not there, Philippe Valenti is not there. You talk about this publication where Philippe Valenti have shown that there are better results if you make the lat dorsi in combination with a posterior repair. This is the paper you talk about, I think. In fact, I cannot discuss this paper because I'm not co-author, but I disagree with my friend Philippe, but I have not the same approach. Because when you make a lat dorsi with my technique, full arthroscopic technique, when you go between the deltoid and the teres minor, and maybe part of the infraspinatus, when you push up your transfer, automatically, per definition, you make a posterior repair. So for me, when I do my lat dorsi, it is, of course, in the same way I do an automatic partial posterior repair, and I do not need to put an anchor in addition. So I think Philippe, who is not there, just probably make a different technique of his transfer, and he considers that the lat dorsi plus the posterior transfer is a good combination. I do the same, but for me it's automatic, and I don't look for a posterior repair because it's automatic with my technique arthroscopic. So what is sure is you rebalance the shoulder. The goal is not to take the cuff over the top and to close the cuff. The goal is just to rebalance the shoulder. Good subscap, but poor posterior cuff, whatever there is, type D or Philippe Pauline, you're right. If the physio is not strong enough to rebalance the shoulder, then the lat dorsi is just here to compensate. And if you're able to repair something, yes, why not? But most of the time in my patients, the surgery have been already done before with a partial repair and a failed partial repair. So I do not try again. And this is the reason why my thinking is different. My approach is different than the one of Philippe Valenti.
¿Alguna pregunta más? Any question? Paul?
Thank you. Dr. Kani, what are your results in improve abduction mostly in patients with posterior superior lesions con trapezius, lower trapezius transfer? What is your experience in these cases?
Yes, maybe we could discuss together. Yes, for me, as I told you, the lower trapezius transfer is a very rare indication. Each year, I do about 50 lap dorsey, but only 2 or 3 lower trapezius transfer. Because of that, it would be very interesting to discuss with Emilio Calvo or Phil Valenti or Bassem El Hassan, because they think different. So my opinion regarding the lower trapezius transfer, I just follow what Bassem said at the very beginning, just to restore external rotation harm at the body. That means the deficit of EA1. In the situation of Emilio Calvo, when the patient is not able to elevate to external and to make ER2, I think the lat dorsi is better. So to elevate and to external rotate ER2, for me, the lat dorsi is better, and you can reach your head like that. With the lower trapezius, you just are able to do that. And finally, but sorry for that, I think this movement is not so important. This one is more important. So in my experience, the lat dorsi is more frequent and better than the lower trapezius. But we should discuss with the others guys who are not here. So I'm sorry for that. Last point, I do not examine the abduction. You asked me about abduction. For me, it's not a good criteria because this not correspond in any classification we discussed with Pascal Boileau. So the lack of elevation, the lack of external rotation, and the lack of internal rotation, we create a triangulation where you can find every patient inside. In none of this classification, we talk about abduction.
Thank you, doctor.
Again, for Dr. Kenny, sorry, I just thought that you was one of the authors of the previous paper that I mentioned. But in the same time, you published another paper where you compare the results of patients with older than 75 years and younger than 55 years. That's a pretty much important and interesting paper, because disrupt the notion and the idea that you cannot make an LTT transfer in patients older, and you found a quite important findings, and I just want to hear your thoughts about your paper, and if you encourage to the panel and these surgeons to make LTT transfers in patients older than 75 years old.
So yes, I published this. It's my last paper, so thank you for having read it. It was just a few months ago.
It was a pleasure to read it. Really.
Yes, and because I was deeply sure that the lat dorsi was also indicated in elderly, because I did it a lot in the past. And for me, making a reverse shoulder arthroplasty, as you have no arthritis, just pain and good run of motion, you know, you may have a lot of complication with reverse shoulder arthroplasty, even in elderly. I don't talk about infection, but I can talk about instability. But I could talk about lack of rotation, because when your patient has a pain for elevation, but good rotation, you put a reverse. Of course, you will cut the pain, you will have a good elevation, but you will lose some rotations. And I'm not sure it's the best technique. And you have to open, of course. And latimus dorsi is a full arthroscopic procedure. It's a one-day surgery, less than 1 hour. No pain after the surgery, less painful than when you pull a cuff, retract it. If you try to repair a massive cuff tear, retract it. When you try to reduce, you make a very invasive surgery, even if it is an arthroscopic technique. You have to put a big pillow, and patient may have some pain and may have a re-tear. With a lat dorsi, nothing of that exists. You just make a tendon transfer. You take it, you turn it. There is no tension. It's ambulatory day technique. And I'm sure it's very indicated in elderly. And this paper shows that the result as au minimum equal may be better in the elderly than in the young patient. Because when I travel in the world, everybody says, and Philippe yesterday, my friend Philippe Valenti, who is not there, said that it's a good indication for the young patient. What is young? This is my paper. 75, you can be young because you can play tennis, you can do lots of things. So for me, young and older is not a good concept. So I think there is no limit of age in the lat dorsi. This is just what I wanted to say. In case of failed, yes, of course, I propose a reverse, but I have very few indication of reverse after my lat dorsi, very few.
Three conclusions that are very important. The first one was that, if I'm not wrong, the first one was that the elderly patients have less rate of re-rupture of transfer, of tendon transfer. The second one was that the patient have a better constant adjusted by age score. And the third was that you don't have to convert or make a reverse shoulder arthroplasty in patients older than 75. And I think that's a pretty interesting results in this kind of patients.
Yes, thank you. Just the point, yes, a previous paper have shown why I had at the very beginning so many ruptures. And we realized with Philippe Valenti that we had some patients were very happy, others were really unhappy, and we had some failures. And we did not understand in the 2010 and 2 or 3 years later why. So some patients were well and others were bad after lat dorsi. And I had the idea to put metallic landmark inside the muscle bellies to try to analyze with just an X-ray whether we have a rupture or not. And I realized that we had at the very beginning more rupture than we could imagine, just because of the tension and the technique of fixation with the screw and the tunnel. Because with the tunnel, you have a killer turn and you have a guillotine effect. Because it's not like with a finger, where you have only 1 degree of motion. In the shoulder, you have a 3 degree of motion, and you can understand that a tendon transfer into the bone can be cut or guillotined. So this is what, and I've shown, yes, with Philippe, we have shown that when the tendon heals, the constant score is much more, and it's really significant. So the goal is to have a good healing, and to have a good healing, now we just fix the tendon not into the bone, not over the top, but just to rebalance the subscap. And in fact, it was the same technique than described by Herzberg 20 years ago, where he decided to fix the lat dorsi onto the footprint of the infraspinatus, but not on the footprint of the supraspinatus, as we did at the very beginning.
Thanks.
Yeah, doctor, a question regarding the setting of loss of active elevation and loss of external rotation, the use of the reverse. So if you're considering perhaps using the lower trapezius instead of the latissimus, just to try to keep the latissimus as an internal rotator, because we know the internal rotation is the less predictable thing about the reverse. So what are your thoughts about, instead of doing the Episcopal, doing the lower trap with the reverse?
Yes, very good question. I had the same question. I asked the same question to Bassem El Hassan 2 years ago. What not a lat dorsi instead of a lat dorsi in a reverse? So when you do reverse, you can make a superior approach, but a deltopectoral approach in France, we think now it's better. If you do a deltopectoral approach for a reverse, the lat dorsi just there. So it's just so easy to take it, to turn it. If you want to make either a superior approach or a deltopectoral approach, in the same time, you want to make the lower trapezius transfer. So in France, we have no allograft like you have in Spain. But we have to take hamstring, then you have to make a second posterior approach. So it could become a nightmare. And it's so easy to make a reverse plus lat dorsi, like Pascal described, and we totally follow Pascal regarding this idea. It's a great idea. But now in the situation, and this is your question is very interesting, you make a reverse, and after 2 years, the patient is unhappy because good elevation, but no external rotation. Yes, in that situation, you can make a lower trapezius. It will be better than a lat dorsi transfer. So lower trapezius in case of revision of a lack of external rotation after reverse.
¿Alguna pregunta más tenemos en la sala? Creo que ha sido una
Any
magistral.
additional questions? Well, this was an awesome and outstanding presentation of the two speakers. Were really clear about the choice of the technique for each one of our of the different mobility issues. Although there may be discrepancies, we must be clear of what we want to achieve, and our gratitude to the doctors for their presentation and their thoughts. So thank you very much.
Buenos días a todos. Ahorita sigue el módulo de ISACOS.
Good morning, everybody. We now have the SACOS module. Due to logistics issues, this module will be performed in Barahona 3. So if you are so kind, we will now go to Barahona 3. Thank you.
Al frente.
It's just here in front of us.
Vamos todos mejor, es más grande.
It's bigger, so we can all go there.
With the most current research for diagnosing and treating their patients.
Get your research
Es la
notice.
investigación más reciente para diagnosticar a los pacientes, que se anote su investigación publicándolo con expertos de todo el mundo.
Lo he dicho, lo he dicho.
Buenos días a todos. Vamos a
Good
continuar
morning, everybody. We're going to continue with the symposium looking at best techniques to repair the rotator cuff and arthritis in the shoulder. We were going to have Augusto Masoka as the moderator, but he was unfortunately able to come and accompany us. So we will now have our first speaker, Dr. Francesc Soler, in person, who is going to talk about the repair and rehabilitation targets for repairs of the rotator cuff. Welcome, Dr. Soler. Good morning. Thank you very much to the attendees. I'm Dr. Frances Soler. I'm from Barcelona, Spain, and I'm part of the Spanish Arthroscopy Association. It has been, I have been delighted to share this session with you, and I want to thank Isakos and Slard for being so kind as to invite me here today to share my knowledge and experience and to be able to bring our efforts together to solve these problems. Okay, as for the objectives of this surgery and rehabilitation in repairing the rotator cuff, evidently the main target of the surgery is to optimize the connection between the bone and the tendon in the footprint, the insertion footprint of said tendon. For years now, a wide range of results in the repairs of the rotator cuff have been described, including good results and bad results alike. So it depends on the condition of the tendon and others. We currently have very good implants and better sutures, but sometimes it isn't infrequent to find the following kind of results, i.e., we can use or whatever technique we decide to use, we still have bad results in some case, re-tears, and this is what we need to avoid in the future because solving this is a big issue, as we all know. And a number of variables have been described that affect the construct and the stability of the construct, as well as healing and the recovery from a repair surgery. But there are two variables that are absolutely fundamental among these, so post-operative biology and the rehabilitation protocol. The main cause for failure of the repair of the rotator cuff is a deficit in the union between the tendon and the bone due to biological factors, as we can see in these images. And there's a weak point here in the construct, i.e. the union between the bone and the tendon. That's where most often than not, the suture or the repair of the rotator cuff fails. Why does this happen? Well, to hook that, we need life. Otherwise, this union will not be repaired. Tendons are not healed through fixatorization. Even if you use better implants and sutures, if there is no life in the tendon, it will not be repaired. It will not stick. Therefore, in our minds, it is difficult to think about cases like this one, where you have apoptotic tissue that's not vascularized. Even if it is a perfect technique, sometimes they cannot repair or heal. Therefore, the first basic objective or target in repairing a rotator cuff is to repair small and medium tears as well, because at the biological level, when the tendon is in a better condition, if we have all the right environment, it will be able to heal properly. When we do not have these conditions, or perhaps we want to add more life to this tendon, we can opt for an augmentation with patches or supplementation with PRP. These are techniques that are within our reach that we can use, but as you all know, and the literature shows us, the results are still unpredictable. And this is very important. There is a critical healing period. If we do not respect biology, then results will not be good. And this critical healing period is a period that is provided by biology itself, which says that 6 months post-op, this construct will be stable enough to finally support daily activities. And we need to base this environment on the rehabilitation protocol. Therefore, the protocol needs to be aimed at ensuring that patients can once again develop daily activities, daily life and work in a normal environment to benefit them on a daily basis. Therefore, in general terms, we recommend that we don't start to do active exercise before 6 or 8 weeks. And above all, in any rehabilitation tip for this kind of surgery, you must recommend recovery of the joint. Therefore, the rehabilitation protocol, what will it be based on? Is it mobilization first or stabilization? Well, I think we need to combine both, because if we only mobilize, but we don't stabilize or only stabilize without mobilization, then the results won't be great. So we need to start with a passive mobilization protocol, then move on to active assisted exercise, and finally mobilization with active exercise. And we need to go from isometric exercises to isotonic exercises. So this is obviously accompanied by a rehabilitation program, because patients need to understand that protocol, take it on, adopt it, and perform it. And this is aimed at avoiding muscle tears and capsulitis, which is always our enemy. These are our enemies in any surgery. Please don't forget about the scapulothoracic surgeries. Any repair of the rotator cuff, if there is no, if stabilization isn't done adequately and the repair isn't done adequately at this level, then the patient will not be happy with the result. So therefore, to conclude this introductory talk to the subject, let's try to treat small tears. The smaller they are, the better their ability to heal and the more success that we will have in our repair. So the protocol should be aimed at protecting these repairs, especially initially, to avoid or reduce the stiffness of the joint. And the protocol should include treatment for the recovery and stabilization of the scapulothoracic joint. And this can be done through a team. You can't simply have the physio and the surgeon and doing everything. We actually need a team so that the patient, who is our kind of target in our work and in our actions, can have a good result. Thank you for listening.
Muy buenos días a todos. Es un placer para mí estar aquí, un honor la invitación.
Good morning, everybody. It's a pleasure to be here. It's an honor to be invited to this table with one of my friends, Guillermo Arce. We've been friends for 25 years. And my talk today is a very personal talk in which I'm going to try to present about the last 30 years of experience that I have in this kind of surgery. I know a few things. You may not like a few things, but this is my opinion. I do not possess absolute truth, but I do have a few truths that I have learned over the last few years. In this video, I have reflected the way we did the surgery towards the end of the 90s. And the truth is that we did nothing. That's the truth, apart from repairing the rotator cuff. Yes.
¿Asisten? Muy bien, gracias. Bien, pues estos artilugios que han ido saliendo a lo largo de los años no han conseguido tampoco mejorar.
Over the last few years, we have not been able to improve results either, but we have learned more from the technical point of view. Are we able to repair this now? Yes, we are able to perform repairs in the union between the tendon and the bone. Technically, we have, but the biology always wins, and this is the first of my truths. First of all, biology, so biology 1, us 0. When you have the worst case for in a young patient, we are able to release intervals and put tendon on the bone. So this is a rotator cuff. Therefore, the answer is no. This is simply putting a dead tissue on a head that has scarce ability to heal. This is why implants and sutures have advanced quite a bit, but we have not been able to control the biology yet. As for the classification, I think this is very important, the size and the number. You already know these concepts. I'm not going to talk about them too much. ISACOS did a great effort in 2012 to create a kind of a consensus of indications to classify those in 2020. It has made this complication or this classification a little bit more complex, but it must also have a clinical pattern because a pseudoparalytic shoulder is very different to one with an active pattern. That's why geometric classifications are in fashion. If we look at the most recent work, and this is my second truth, classify, classify, classify. So if we look at partial thickness, we are talking about many different things, the tendinous, the intratendinous, the joint, the bursal part, and they have very different treatments. And the intratendinous ruptures are conservative, you can control progression and maybe add biological infiltration. The partial joint rupture is very interesting. In the last few years, it has become very important to look at the superior capsule, and we know that it's almost fully capsular in the anterior part, but in the posterior part, it's much more linked to the tendon. Nevertheless, all tears in the bursal part are tendinous there, therefore the tendon is affected. So another truth for me is that the partial anterior lesion is not a rotator cuff pathology, it's linked to the tendon. So you're affecting, there's usually an unstable and painful biceps, and so usually you have to treat the biceps rather than the rotator cuff. On the other hand, we've seen that these rotator cuff ruptures have a certain evolution compared to complete tears, and none of them practically erupt until, I mean, it's hard to heal partial ruptures because they have been altered, but in patients with these kinds of tears, you can achieve good results with conservative treatment on its own.
¿Cuándo el tratamiento quirúrgico? Pues
Okay, when do we have surgical treatment? So 50%, I think this is rather reasonable, but localization, as we said before, the location is important. Nevertheless, the bursal tears will require repairs almost always. What is the best technique? So there aren't significant differences between transtendinous repairs and completing a rupture. I personally prefer to complete a rupture. Something else that's important in complete tears is to understand the shape and the pattern of the tear. Each tear will have optimal treatment. It's very different when you're treating a partial one, and other ones that affect more tendons. And for this, the spine of the scapula is our reference to understand the type of tear and design the treatment. And this is my fourth truth. Each version requires its own specific repair. There's an internal debate about whether we use double row or single row or triple row. So this is very fun. The truth is that there is no consensus at a universal level yet. There is a trend with a double row, but there are no trends. This obviously increases costs which we have been highly subjected to lately. The humanistic doctor of the century, of the 18th century, just to talk about this invention, the tenotomy is a great ally in the treatment of the pathology of the rotator. It is a 20-second technique that's done very, very quickly, and it's quite a bit easier than tenodesis. There are other indications for tenodesis. I tend to use it a lot when there is a complete or an unaffected rotator cuff. So if you do nothing, you will basically regret it always. So I think that my technique is based on the knee, on the ACL, with suspension, tendon suspension, which is similar to the ACL, and it uses suture. So we have the suture bridge technique. I think they use the most in repairing rotator cuff. You need 4 implants. You need 2 patellas for the portal. So I use 2 portals, a posterior medial. I look for the straight line, of course, because we did not have curved instruments in the past, so I got used to this method. And I'd like to talk about Mr. Mehata, our friend, who he's brilliant. He invented this. This is at my home. We know that there are strong points and weak points, but it's a very expensive technique. It's been designed it was designed when replacements had not, or reverse replacements had not been approved in Japan. The results aren't as good as you could expect. Using a graft that is higher than 10 millimeters can help aid results. So I do it this way, similar to tendinosis, and so it's quite expensive. And so with regards to the balloon is a poorly understood element because it provides little distension. More than 100,000 have been inserted, so it's a kind of fashion. But other treatments of irreparable tears follow the standard towards HLQQ 8085. Absolutely all of them have 83% of good results. So we have balloons, transfers, and then a new cycle, which is still pending for confirmation in terms of whether it's good or not. So we need to understand the values and how a shoulder works. We need a stable scapula with 120 degrees of elevation to be able to control it. Then after this range of mobility, rotation of the scapula achieves the following. This is truly important. We need to understand the biomechanics and control the entire process of physiotherapy. If we want to distend the humeral head, this is a balloon after a week and then after 2 weeks. So you can see that it's in its place. We can't do it like this. If the target is the humeral head, balloon 6 months later, capsule reconstruction 6 months later, and partial repair months later. If we want to extend, we will need a replacement or a working rotator cuff. So this is my next truth. I quite like using this technique. It works like many others, and it's able to give you lost mobility. It gives patients lost mobility for patients that do not have an irreparable tear. So I think this is a good element. It improves the scores for the muscle. So I think that the lesson for this treatment will depend on many factors: subscapular presence, activity, clinical patterns. All of this will give us a whole range of elements that we need to choose. We need to offer the most predictable result to our patients based on these parameters. So we still haven't solved the biological issue. I think there are many options for the future, but we need to advise patients adequately and perform controls with physiotherapy. Thank you very much.
Muchas gracias, Ángel, por compartir con nosotros con esta sinceridad.
Thank you, Angel, for sharing with us so honestly your experience over the last 30 years devoted to shoulder surgery. It's wonderful to receive such clear information. To continue with our program, the next conference speaker is Dr. Gus Masoka. He is the current chairman of the Shoulder Committee of ISACOS. And the truth is that he is very enthusiastic with his work. He does great work, and he is highly devoted to this particular activity. He was unable to come here today due to a number of difficulties in traveling, and so he has provided a telematic presentation.
Hi, my name is Gus Mazaka, and I want to thank the Slard group for inviting me for this presentation on subacromial bursts as a source of pluripotential stem cells for biologic augmentation and rotator cuff repair. These are my disclosures. Obviously, a large group of people have worked on this. And the main point here is that subacromial bursts may be an alternative source to assist with biologic augmentation and rotator cuff repair. Burst is not a new idea. There are two different areas above the tendon and above the muscle. It contains large amounts of connective tissue progenitor cells or stem cells. It demonstrates high proliferation potential regardless of patient demographics and rotator cuff tear characteristics. And there's no difference in biologic activity between the bursa cells in a revision and a primary rotator cuff. So multiple animal studies have shown that tendon healing cells do not originate from the bone or the tendon, but really the peritoneum. We believe that the bursa is the peritoneum on the rotator cuff. We believe the cells needed to heal the rotator cuff are contained in the bursa. The history of bursa has been around a long time. Dr. Golke really talked about this in 1991 and 2007, and there's been a lot of work since that time. You can see what he was saying back in 1991 about bursal expansion during rotator cuff tears as a reparative response rather than degenerative. So biologic activity of bursa. How are connective tissue cells or stem cells defined? Well, they're defined by these ways. They can differentiate to bone, fat, and cartilage. They form colony-forming units. Their morphology is characteristics by attaching the tissue culture plastic. And fact analysis looking at CD 73, 90, and 105. So let's compare the bursa to concentrated bone marrow. So 1 milliliter or milligram of concentrated bone marrow, you can see that the average amount of colony-forming units is significantly more with bursa. Cellular morphology, similar between bursa and concentrated bone marrow. This was an experiment we did where we looked at bursa over muscle, bursa over tendon, and control. And you can see how much more active the bursa is compared to concentrated bone marrow. Live dead assays with green being viable and red being dead, significantly better with the bursa. Fact analysis, CD 105, 90, and 73 all show similarities between concentrated bone marrow and bursa, meaning those are all stem cells. This is just an electron microscopy view showing that viable cells in both bursa and concentrated bone marrow, autologous fibrin clot. So we first looked at this animal model. What we wanted to do was to recreate what we were doing with this mouse, which has significant very similar genetics to the humans, but these genetics can be manipulated so that we can provide a really controlled environment. And then what we did in this study was evaluate the effects of the bursa cells and tissue on supraspinatus tendon healing. And then we didn't think there would be a difference between the tissue or the cells. So what we looked at is at 2 and 4 weeks, we biomechanically tested them and showed that there was a significant increase in force of the tendons repaired with bursa cells, as you can see here. Then we did the part 2, where we looked at what we call grab and go, which is what we do in the OR, right? We take the tissue and we immediately implant it at the repair site. And once again, we found that we were successful. So cultured bursa cells, derived and fresh, both led to an increase in failure force of the repaired supraspinatus tendon. So how to quickly and effectively prepare in humans. So remember, like I said, the bursa is two parts. There's a bursa over the tendon. And in fact, you can see that you need to break down the bursa with a shaver into a slurry. Unprepared bursa will not release its cells. There are more cells in the bursa tissue over the tendon than the bursa cells over the muscle, and the cellular composition of the bursa is really dominated by these progenitor cells, as you can see in this graph. What patients are indicated for all autologous biologic augmentation for arthroscopic rotator cuff repair? Primary repairs that are large, or the provider feels that they have some type of biologic compromise, diabetes, smoking, use of a walker. Then you can augment with this all autologous bursa, platelet-rich plasma, and autologous thrombin. The size of the tear or age of the patient does not make a significant impact in the cellular content of the bursa. Why is the clot important? How is it designed to increase and promote cell growth and incorporation? Well, PRP is added to the clot secondary to its ability to normalize matrix metabolism, facilitate the recruitment of these mesenchymal stem cells, and it shows a twofold increase in proliferative compared to controls. Platelet poor plasma, which is also part of the PRP process, contains high concentration of fibrinogen, which in actuality creates the clot. So as the fibrinogen was increased, so did the clot size and thickness. Too thick, the cells don't grow. Too thin, it becomes water. So we simplified the autologous bursal clot during surgery for rotator cuff repair. We draw 52 cc's of whole blood and mix it with 8 cc's of ACDA, which is an anticoagulant, not heparin, as heparin will stay in the system. So this is, the ACDA has really helped us make this clot much better. 40 cc's go into the centrifuge for the PRP, PPP, and 20 go to the autologous thrombin extraction. This is drawn from the centrifuge and then mixed. We use an arthroscopic shaver connected to a device called Collect all of our bursa, and it breaks it down. We have looked comparing different shavers, showing that the shaver does make a difference in how many cells you can get. We then strain it through this Telfaplat to remove all the excess fluid and isolate the tissue. The PRP, PPP, bursa, and autologous thrombin are added to the syringe to make a fully autologous clot. We look at this. You don't need to do this in the OR. We try to make it as warm as possible because that'll create the reaction to make it a thicker clot. You also don't want to make the clot too early because it'll decay over time. So we implant this various ways, but really we've used this 14 gauge Jamshidi needle where we put it below the double row and above our double row. And you can see the clot with the bursa progenitor cells over the top of this. The size of the clot can easily be adjusted to make a small, medium, or large, as long as you keep the ratios the same, which are 6 parts platelet-rich plasma, platelet-poor plasma, 2 parts thrombin, and then the rest is bursa. Human outcomes, these are what we've done up until February of 2021, 62 cases. We've had 6 failures. The colony forming unit does not seem to have an effect on failure rate. The failures are in red. We then compared it to an arthroscopic double row rotator cuff repair bursa, which had an 8% re-tear rate versus a standard arthroscopic double row rotator cuff repair as a control, which had a 29% re-tear rate at 6 months. These are the papers that we published up until 2022. So we've done a lot of work on this to try to make this better. And just in summary, bursa is not a new idea. It's been around. There are 2 different areas, the bursa above the tendon and the bursa above the muscle. Bursal tissue does contain large amounts of connective tissue progenitor cells or stem cells. We believe the bursa is the paratenon of the supraspinatus, which aids in healing. There's no difference in biologic activity between primary and revision. Thank you.
Thank you, Gus, for staying with us, connected. We'll have some time for discussion to share these cases. Our next speaker is Guillermo Arce. There is a problem there's a mistake in the program because the title of the topic he's going to address is not non-arthroplasty options. No es el título que he puesto aquí, es biceps, don't have the biceps tenotomy. O sea, problemas con la porción larga del bíceps. Guillermo.
Gracias, Emilio. Gracias a usted por estar aquí. La idea es...
Thank you, Milo. Thank you for being here. The idea is to talk about the possibilities of having biceps. These are my disclosures, which have no impact in the presentation. The shoulder surgeons work really hard to achieve two objectives, which is to reduce pain and function. Sometimes with a very sophisticated technique, the bicep is worth it because this is a great pain generator in terms of instability, as you can see on the upper picture, and the degenerative problem. So that the diagnosis is quite simple. This is we use the one finger pain and biceps and the speed test. TAC is conclusive. We need to determine the different actual with the peritendon synovitis. So these are quite simple. Some of them are more complicated for sport people or who require some anesthesia infiltration to determine if the biceps is the cause of the problem. And I think that the ecography with the dynamic evaluation of the biceps is a tool that is quite useful. As you will know, the LHPT instability may be due to the coracohumeral ligament, the MCHL and ACHL. And this photo of Pobolanon, the arthroscopy picture on the top, the most common one is the middle instability through the substeers. Oftentimes we repair the substeers and we do the tenodesis because we believe that despite the fact that we have repaired, this is not going to be sufficient to have a good pulley. As tenodesis technique, people have to be trained, and Angel likes the tenotomy, but as shoulder, you need to train on the different techniques, because if you do this tenotomy, be it the sports person or the person required, and this is quite a, if you do more tenodesis compared to what you have for low demand patients, you will be trained and the surgical skills to do this. And throughout the years, we have used the last loop in double row, but we normally tell the patients that the weak link is not the anchor or the bone, but the tendon itself. So we normally try to do a double row with the last loop, and oftentimes we use the loop and tack technique. As you can see there, you can see we have a loop. It is quite, and then the tip of it is used through the scorpion, through the biceps, and then not, and then we use a knotless anchoring. This is the most commonly used technique when we plan to do a speed bridge. The first anterior anchoring, or in our case, will have a fiber tape, and we use the sutures, free fiber link, or we use a suture of the same civil lock, and then it's going to do the loop and tap technique to do the tenodesis, and then there will be two fiber plates in order to do the speed bridge. This is a technique that lasts 1 minute, perhaps angels may last 10 seconds. This may take 2 or 3 minutes, but this is good for low demand patients and athletes or reports. People, we have published the supra pack, the arthroscopy portal. In the different portals, you need to open the rotator interval in order to define or identify the bicep. When you go to the bursa, you need to open the rotator cuff to look at, and then we go all the way down until we find the tendon of the pectoralis major. And these images must, if we use a switch and stick as a retractor, a separator, once we get to the bottom at the pectoral level, we use the switch stick or a stem, inserting, this is a static separator in order to work and to do the socket, as you can see there. And then after doing the socket, we push the bicep with the anchoring and the socket. So we need to bear in mind that that these screws are 19 or 20 millimeters. So you need to take the bicep to make sure to avoid overtension 2 centimeters above the hole, in order to introduce it within the hole, so that we achieve the right tension, 20 millimeters above, in order to avoid any bicep overtension. So this is another technique that I wanted to share with you that we commonly use. It was described by Stephen O'Brien, which is what we do when we operate. Can we play the video, please? We do it with scorpion. In order for them to take 2 fragments of the biceps, you need to use or pass the legs on the bottom. The legs go behind the tendon. So this is a technique that is quite simple, very easy to use. It's not as easy as the lasso loop or the loop and tag, but this is a technique that can help you rehabilitate the patient. It connects the long part of the biceps, is connected to the shorter portion of the biceps. And these patients, once they have these 2 points, and after they do the tenotomy of the bicep with 2 points, you can perhaps not immobilize. You can do an early immobilization, and that's you can see the whole tendon and the short part of the biceps and the long part of the biceps. You can see them, and with the points, without any need for any anchoring. We have done tenodesis, as you can see it on the left. There are some patients that break the tendon, and this is the only opportunity that where we do an open subpack tenodesis. These patients are demanding. They come to see us with this type of signal. This is a technique on the bottom part of the axilla. Then we do it on this area where this cannot fail, because I'm a physical culturist, or they prefer the prior fixture. So we install a distal anchoring, and we pass it twice through the tendinous muscle joint, and then we have a second row. Then we have a crackle point, and we install another civil lock. The application in a double row with at a distal level, and not less at a proximal level for the fixation of the open line. So the conclusions, I think that that this is the biceps tenodesis is a win-win situation that will reduce post-operatory cases. I would do a lasso loop or a loop and tag, which is a 2-minute technique for intermediate patients, where I want to do a bicep tenodesis. the tenodesis and only for high demand patients or sports people who requires a very strong biceps, I would do a arthroscopic one with screws. This I was invited. I was invited to write one of the chapters, and I wrote something in this book. I wrote the chapter on biceps tenodesis, and you can see the technique. Just to remind you, like the other time, there will be a hands-on course with Anna in Miami in next November, and we will wait for you in Boston in 1 year and a half. Thank you. Thank you, Guillermo. Awesome as usual. Our next, we're going to have Pablo Narbona from Argentina as well. And Pablo is going to talk about a very difficult topic, which is how address with non-arthroscopy options the massive cuff tears and revisions. Thank you to the scientific committee of Slard. And thank you to SACO for inviting me to this presentation. I'm going to talk about the non-arthroplasty options for massive cuff situations. This is my disclosure. To talk about this, we need to know, we need to recognize the problem that we're facing. This is a problem where we may have some massive ruptures, and we need to address the poor quality of tissues. This is something that we're going to have very commonly in the re-rupture of the rotator cuff, but it will be but this also involves a massive environment with biceps, or in a better environment for us, and or with the hypertrophy, as you can see in the video. So we're going to think about the reparation in the rotator cuff augmentation, to augment a little bit the rotator cuff. So we can do this by inserting a graft. We can do an interposition, so the graft will be a bridge or a gap between the repair and the remaining tissue, or by doing the reconstruction of the superior capsule as in this, or by doing an augmentation of the rotator cuff reinforced by the biceps tendon. So the superior capsular reconstruction can be done with an allo or auto graft, or a local augmentation with biceps. These two techniques will allow us to biologically restore the biomechanical logic of the shoulder. This will allow to preserve the articulation. And in terms of massive ruptures, sometimes considered irreparable, which is what Dr. Burger indicated as a biological reverse. How to do it? The main objective of this technique is to avoid what you can see in this video, which is the anterior superior migration of the head, and how by doing tenodesis, or the increase of the augmentation of biceps, we're going to avoid this escape of the anterior superior. My technique in very degenerative tendons, I do an augmentation because I'm not going to be able to repair it. Then the ideal in this case, when I have a calcified tendinitis, I like to have a biological bed. I'm going to look for the biceps tendon. I'm going to have 2 loops. These points are really strong. Oftentimes they will not detach. So it is essential to have 2 to provide more fixation to the tendon and biomechanics. Then after I do this, I'm going to complete the tenotomy on distally, and then I'm going to increase and I will transfer the insertion of the posterior biceps. We do the fixation, and then once the fixation is done, I do a reconstruction with the dual row with four out, everything is knotless to obtain the repair, to achieve the repair. So this function is not just a biological augmentation. The biceps tendon is also going to work as an internal biological brace. So it will allow us to reduce or to lower the humerus head for a better healing of a tendon with very poor quality. Barth published recently this work where he compared three groups of similar patients, dual role equivalent with augmentation of biceps. It was an interesting work, and it has very similar outcomes in the three groups, but the reach here in the SS and in the infra and the IS had very significant statistics in favor of the augmentation of the biceps and 0% re-tear. As to the reconstruction of the superior capsule, this is something that was explained by Mihata in 2012, and the main objective of the upper capsule reconstruction is to restore the GH physiological relation, limiting the upper humerus translation, and to allow a more anatomic approach. So this is something that we can do through autograft from fascia lata, or with the dermal allograft, which will reduce the surgical time, and also the morbidity of the donating zone. But sometimes, due to lack of availability, regulatory problems, we need to use the allograft. So we refer to the literature to determine what's the difference between autograft and allograft, and the systematic review indicates that with both grafts we can obtain similar results, and in the revision published by Kim in 2020 also indicates that with allograft and autografts we are going to have clinical or very similar clinical results. My favorite technique, together with Dr. Barkley, we described this technique, which is being published. We call this SCR knotless internal brace, and we're using the fascia lata autograft due to regulatory problems because we don't have allografts. So we're suggesting to have a medial with a knotless anchoring of 3.5 millimeters. And the most curious thing is the preparation of the graft, where we're going to pass the fiber tape, the lateral tape, and then we're going to have two sutures which will go from medial to lateral, from up to down in a descending order to reconstruct the posterior brace. Then we check the biomechanical tests. So we achieved a very strong reconstruction. So the technical recommendation is to the devices in the glenoid insertion. This is the technique. We did the debridement at the humerus level on the upper part, supplemented at the glenoid, but there's a biological bed. We confirmed the irreparability. We do the partial reparation of the remainder in the posterior part with an internal, knotless internal brace. We have a on the middle, on the make it technically easy. We have the internal brace, the posterior in the interior. We do the fixation with a 3.5 knotless anchoring, and then we complete the reconstruction with an equivalent modified technique and a suture of the internal brace. And then we do the fixation, the lateral, anterior, and posterior fixation, and then the sutures on both sides to adhere the graft to the remainder. We use the internal brain as a stop for the sutures. You can see how we're doing the sutures between the anterior and posterior remnant of. We normally recommend to do side-by-side sutures to provide stability and augmentation and vascularization to the graft. And also, there are several articles that show the clinical success, the AHI and the radiographic healing in the different systematic reviews also provide good results. Both studies have indicated clinical improvements and functional improvements with similar index of ruptures. This is a 64-age patient with an irreparable rupture pseudoparalysis. Then we do the reconstruction, and 6 months after, we can see how the capsule is integrated, the superior restoring the articular biomechanics and reverting the pseudoparalysis. We have 36 patients that are being published. The recommendation, the thickness of the graft is essential to restore the articular or the joint biomechanic. It's providing a better spacing effect and will allow us to descend in a more safer the humerus head. This is not a conventional rotator cuff surgery. I think that it has to be used to protect from 6 to 8 weeks. The use of the knotless internal brace technique is very important. It will allow us to protect the patient. We need to think about the construction of the upper capsule in patients with minimum degenerative changes. Thank you very much. And I want to invite you to the Congress in Argentina in September of this year and to the ISACO meeting in Chile in October. We're going to have some time to discuss this and to exchange experiences. We are increasing the complexity level when we talk about this, and we're getting to the last part, which is reverse prosthesis. We have today Dr. Felipe Valenti, who is going to give us his vision and
Philippe habla español.
Okay, go ahead, Philippe. Philippe speaks Spanish, and yesterday he promised me that he was going to speak Spanish. I think he said this at the dinner where he felt a lot stronger. If there are any questions, I will respond in Spanish. Okay, thank you very much, Emilio. Thank you very much, everybody, for listening.
We talk about the indications of reverse curvature arthropathy technique, tips and tricks, and I show you a video on the video of planification preoperative on the result. So you know very well that the pseudoparetic shoulder is the classical, the good indication. Can you show me the video, please? Okay, this is the antero-superior migration of the humeral head. It's very important to define the pseudoparetic shoulder. The pseudoparetic shoulder is the antero-superior migration of the humeral head, static or dynamic. In this case, it's dynamic. So the second indication is Amada 3 or 4. This is a complete palsy. This is a swelling shoulder. This is very painful shoulder. There is no case. Is Amada 3. And another indication is a big destruction of the bone, and this is an emergency. And when you see a patient like that with osteolysis of the acromion, you have to do operation as soon as possible. This is risky for the infection because there's a lot of fluid, but I think that you have to operate as soon as possible with a reverse arthroplasty. So this is a mistake that you have not to do. If you have a massive curved tear with a subscapularis tear and supraspinatus tear, and you have to repair, but you have to respect the AC ligament, because if you cut the AC ligament in massive anterior superior curved tear, you have a risk of pseudoparatic shoulder. This is a big message. I think that acromoplasty on section of the ACL, when you repair the subscapularis, is not recommended, because if you have a failure, you have a superior migration of the head and you have a pseudoparatic shoulder. So this is a case of a lag sign. You see that it is pseudoparatic and there is no active external rotation. Many surgeons now that talk about reverse lateralize is enough. I think it's not my experience. If you have no motor, if you have no teres minor, even you lateralize the prosthesis, you cannot restore external rotation, the arm at the body. And I think that is better to combine tendon transfer. So when you do a reverse, it's very important to analyze the glenoid. And the most important is the superior inclination, superior erosion, E2, E3, E4. And there is a high risk of superior tilt. And if you put a superior tilt with the reverse prosthesis, is immediately a risk of instability on glenoid loosening. Is very, very important. It's a Favre classification. So I do systematically a CD 2D, but now I do 3D, and I use for all the prostheses a preoperative planning with a software. Why? Because for the fellow, this is a very nice education. You can see the glenoid in 3D reconstruction, and I show you. It's important to evaluate soft tissue because in the glenoid B2, B3 or C now on all patients, I do reverse arthroplasty. You have to evaluate the teres minor, you have to evaluate the subscapularis. And with the software, you do an automatic segmentation and it's very useful. And now 2D is not enough if you want to do a reverse arthroplasty. You have to remember that there is a reverse angle for the glenoid. If you consider all the glenoid and if you consider the inclination, you have the beta angle. But when you use a reverse arthroplasty, you use many times a small metal back and very inferiorly. And Pascal showed very well that if you compensate with the bone, you have to compensate more. And it's very important to understand that. And the RSR angle is the most important to consider the compensation with the bone graft back to the posterior metal back. And the metal back is very, if you use a small metal back, you have to use a bigger bone graft if you want to obtain inferior tilt. I do a 2D, I do a CD, now I do a software with appreciation of inclination and version. This is an example, 65 years old, you see that, it's still painful shoulder. And this is here, this is a posterior subluxation. You see that is important, it's a glenoid B2, and you evaluate superior migration. And now I use a video, please. You use a software and you have a 2D and 3D reconstruction. You see the coronal plane, sagittal plane, and you remove the humerus. You evaluate the version of the humerus, version of the glenoid. And after you remove and you evaluate the deformity of the glenoid, is very important for the education of the fellow and for my education, of course. And you evaluate the native version, you evaluate the native retroversion. You can evaluate the relative, depends on the size of your metal back. And before the operation, you do that. And after you choose your implant, it's important to very low, inferiorly, and you measure the center of rotation. And if you do anatomic, you can use the same. And the concept is to correct the version. You accept 5 or 10 degrees of retroversion, but you accept 0 degree of superior inclination. I prefer to put 5 or 10 degrees. You can measure the reamer. You can measure after the lateral offset. we have a new software for the lateral offset to measure also the lateralization shoulder angle, distalization shoulder angle, and you can simulate the prosthesis that you want to do. And after you use a PDF, and it's very useful for the surgery. This is a PDF. I use this guide. It's a reusable guide because PSI is very expensive for me. And I use this guide. We have 12 possibilities to correct version and to correct inclination. And I show you a short video. This is the rules that we respect. You see that? Version stem, 20 degrees. Good alignment with the glenosphere base plate, inferior tilt, flush the inferior border, lateralization to increase externalization, distalization to increase the deltoid strength. If you put the prosthesis in curvature orthopathy, you have excellent results. This is a short video. Sorry for the time, but I think that is important to show you. The deltopectoral is lateral to the coracoid process because it's useful to have a good exposition of the glenoid. We have time to do. This is 5 minutes. It's okay. Sorry. And you look for the deltopectoral approach. It's very easy in the superior part. You see that there is a fat tissue in the superior part between the pectoralis major and the coracoid process. You see that the quality of the picture, and I use the VIMS, and this is a 7 key, and I think that I am surprised by the quality of the picture. I don't cut the pectoralis major. I protect the deltoid. Systematically, I do a tenodesis of the biceps to the pectoralis major. This is the first. And after I do hemostasis of the circumflex artery, I do tenodesis with non-absorbable suture because I don't want a Popeye sign. And you define the superior part of the subscapularis. You define the inferior part of the subscapularis. I use a peeling technique because with the peeling technique, you can lateralize your reinsertion. I tag the subscapularis. Inferiorly, I identify the latissimus dorsi because the latissimus dorsi is the inferior limit of the subscapularis. And I detach completely subscapularis capsule until 9 o'clock. 9 o'clock to have a good exposition of the glenoid. It's very important to release the capsule, to release the subscapularis until 9 o'clock. And after you do the prosthesis as you want, there is not a problem of the prosthesis that. I prefer to use a guide because if you have a malunion, if you have a modification of the anatomy with a guide, you decrease the risk of malalignment. And I prefer to use a guide. And for young surgeons, for the retroversion, is useful to use a guide, but you can use freehand as you want, freehand on the anatomical neck. So I take the graft on the head because many times I put superior graft for the glenoid. So this is you take time. You have 2 slots, and you can use the 2 slots to obtain a good graft from the head. It's very useful. And after you remove it, and you remove the head. Of course, I respect the cuff. In this case, there is no cuff, but if there is a cuff, I respect the infraspinatus. I respect the teres minor in my cut. And after I protect the humerus with a platine. So if you release the capsule, if you release the subscapularis until 9 o'clock, it's very easy to see the glenoid. And you put the posterior inferior retractors like that, and you are just in front of the glenoid. Exposition of the glenoid depends on the release of the capsule on the humerus. This is a key point, I think that. And after you put 4 retractors, you do a circumferential capsulectomy. And now is important, I measure the point, the central point. And you measure 15 millimeters depends on the preoperative planning. And you can reproduce the preoperative planning. It's not important the deformity. You have to reproduce the operative planning. And the most important is the central pin. If you use the good positioning of the central pin after it's finished your operation. Because you can, you use the guide, you see that? You put 10 degrees of inferior tilt after you ream and you put the graft. I think now, without any preoperative planning, even the deformity is not very important. I think that you can do mistake. And with the preoperative planning, if you follow for the young surgeon, you can reproduce completely the preoperative planning with this system. I know that software is very useful today, is not expensive, is on the Wi-Fi, and you can use it, and it's very comfortable after when you do the surgery. Because you follow, you see that you follow the pin and you put your base plate. At the end, if you advance at the end, I think that is important to repair the subscapularis, and I repair the subscapularis with a double row. Okay, maybe I will advance. Maybe I increase, I put the bone graft, and after I impact, I put the bone graft here, superiorly and inferiorly. We can measure the bone graft, and now you impact it. And you have a press fit, a good press fit. And after you put 2 screws and you perforate. The bone graft superiorly is the key point. We did a CT scan and we have no failure because this is a compressive autograft with inferior tilt. You have no osteolysis of the superior bone graft. It's not a bio-RSA. It's different. I feel the empty back to the base plate. It's completely different. And after, it's important to repair the subscapularis in my experience, because the subscapularis is very useful for the stability of the shoulder and for the strength, not for the mobility, because Gerber test is always positive, but I do a transversal suture, and it's important at the end of the operation to obtain 30 degrees of external rotation. And I do a double row. Double row is important because I put bone graft. And double row is important. It's better to put bone grafts than cement, in my experience. It's biological cement, and you reduce very easy. And after you repair the subscapularis. And with the peeling technique, you can lateralize a little the subscapularis. If you cut the subscapularis at the junction between the tendon and the muscle, you cannot lateralize. And I think that is important if you use a lateralized prosthesis to have a peeling technique or a small bone as you want on the great tuberosity to increase the. Thank you very much. And it's finished now. This is the result. And this is the result of this patient. So this is a patient with 15 years follow-up. And the conclusion for me is that the reverse in cuff teratopathy is a very nice prosthesis to restore active forward elevation in pseudoparetic shoulder. I think that lateralized prosthesis is good, but if you lateralize on the glenoid, you have to lateralize on the humerus because you maintain the lever arm of the deltoid. And to restore external rotation and to avoid glenoid notch, I think that lateralized reverse prosthesis is a key point. And I revised my patient with more than 10 years now with the reverse arthroplasty. We have more 200 cases. And in 90%, we have no glenoid loosening, no humeral loosening. And in my experience, I have more complication with anatomic total arthroplasty at 10 years. Thank you for your attention.
Thank you very much. Muchas gracias, Philippe. Voy a pedir a los conferenciantes que por favor suban al podium para participar.
I will ask the panelists to come up to the podium to participate in the discussion. We can ask questions about the different subjects that have been touched upon, and we can also discuss a series of clinical cases. Mazoka has been with us for a while and has shared information with us, and we can definitely discuss different alternatives here, these difficult cases. Can you see the screen of my computer to look at the clinical cases? Perfect, thank you. This is part of the cases that Gus has very kindly sent to us. The truth is we could fill a number of sessions with it. It's great because I try to choose the ones that give us more opportunities for discussion. This is the first case. a right-handed worker. She's 42 and she falls off a ladder.
Intenso que
She
progresivamente
comes to the clinic with intense pain that slowly improves. There is pseudo paralysis and she's unable to lift her shoulder. This is a young woman. We asked for an X-ray where we can see the relationships between the humeral head and the glenoid. Would somebody like to comment on these images?
parecen unas radiografías bastante normales. Puede haber
It looks like a rather normal X-ray. There's a slight elevation of the humeral head, but that's it.
querréis ver todo es una resonancia magnética de esta
And you
paciente.
probably want to see the MRI for this patient. This is the MRI. Would somebody like to comment on the findings for this MRI? Philippe? There's a subscapular tear, I believe. Could be the supraspinatus on the right, upper right. The quality isn't great. I think there is a clear tear, grade 4, type 4 of the subscapularis. And at the top, you can't see the supraspinatus too clearly. Well, you can see it clearly, sorry. Pablo? I think there's a Hagel lesion in the inferior capsule. Maybe it's the subscapularis tendon that's been pulled back. But I'm worried about all that trauma. This is a young patient. And it may be linked to tearing the capsule of the humeral, and it creates an inferior lesion. Gus, can you hear us?
Yes, Matsuoka, can you hear us?
Yes.
So we're discussing the MRI of this patient, of this case you sent gently to us. And there is a large tear of the subscapularis. Probably there's a tear of the supraspinatus as well. But there is a comment in the room about the possibility of Hagel lesion. It's an acute traumatic tear. Do you think there is a Hagel lesion in this case for this patient?
Yeah, I thought that was a great comment on it. There was I think in the next slide. Not so critical. I do not do a Hagel repair on these people. I'll fix the rotator cuff and then rehab them. If they develop, which has not happened in my experience yet, instability, then we could go back later. But generally speaking, the rotator cuff repair, both subscap and supraspinatus, can take care of both. I know that, double row versus single row, whether people are go on these acute tears for post-op rehab.
Okay, thank you, Gus. Let's try to go step by step. Let's first talk about what is the preferred timing for surgery in these patients with acute tears. We are dealing with a young patient. Es una paciente de 42 años con una rotura.
This is a 42-year-old patient with a severe tear. When would you? As soon as possible. with double row. So no chorecoplasty or subacromial decompression. If it was an older patient, so over 65, well, I think the same. I think it has led to pseudo paralysis as soon as possible, and the best possible way with the best tissue. I'm worried about the stump on the MRI. That can make, well, it's not so much on the union, but we may have to make the insertion medial to avoid exerting too much pressure. Well, there are poor studies that say that there's no difference between medializing the insertion of the subscapular. So
I agree with Arturo. I think that in young patients, the atrophy of the muscle and fatty affiltration in athletes, for example, is very, very fast. And if you wait, it's not good for the recovery. This is the first point. The second point, that if we have an old patient with pseudoparalytic shoulder, with traumatic case, I do operation early. You have not to wait, because pseudoparalytic is not indication of reverse, it's indication of repair the curve in traumatic case. And for me, 6 weeks is possible. The second point is double row is very important. On the third point, I respect the AC ligament, I respect the acromion. This is not an indication. And contrary to Tony Romeo, who does coracoidoplasty, I don't do any coracoidoplasty. I don't understand why you go to the bone. The bone is normal. There is no problem.
And the problem is not impingement. It's a different problem.
Yes, it's not the problem. You have for the, but sometimes retraction like that, you have to see the axillary nerve. And it's the reason why you put the scope anteriorly and you have to look for the nerve. Because when we release the tendon, if you don't release the nerve, you have a risk of electromyographic block of the conduction of the nerve. And sometimes I have a transitory palsy, and for the postoperative, it's not good. And
this is a very interesting point, because we all know that you're very experienced in the management of brachial plexus lesions and nerve lesions. What are your indications to release or to check the nerve, the axillary nerve and the subscapular nerve when doing a subscapular repair?
In
This was type 4, wasn't it?
Yes, 4. I think that I will see to the axillary nerve.
Thank you. Pablo, ¿algo que comentar?
Any comments, Pablo? I would just add that I would operate as soon as possible after recuperating the passive movement of the patient. It's important to go into theatre with good passive movement. It's important to recover passive movement. If it's stiff, this seems to be quite an acute case, and they may not have stiffness, but I would try to recover complete mobility before moving on to the recovery. Yes, there may be evidence of pseudoparalysis, but for me it's important to not worsen the stiffness with the surgical procedures. It's also interesting how to address stiffness linked to a rotator cuff tear. Some say you need to recover passive mobility, as Pablo proposes, and then perform the repair. There are surgeons that say that this is not necessary because you can perform a release of the tendons. And when you perform the repair, there are techniques or studies that study both techniques. What's your experience, Angel, with tears and stiffness? In an acute case like this one, I don't think there may be stiffness. I think we would have to wait in this case. And would you do the release at the same time that you do the repair? Yes. I mean, when they're sleeping, they will have complete passive movement, I assume.
Estoy de acuerdo con ello.
I with complete passive movement. Normally, these are procedures that have a greater time of evolution. When there's pain, that reduces mobility, but when they're sleeping, they do have passive mobility. I just wanted to specify something about the subacromial decompression. In acute cases, it's difficult for the subacromial part to be compromised, but then in chronic cases, we need to understand that the anterior and superior subacromial space depends on the position of the scapula. So when we pull it back, restoring the adequate kinematics of the scapulothoracic joint, this space, the subacromial space, becomes bigger. So it's not a closed or tight space, it's not a passive space, it's an active space. It depends on the position of the scapula. So we need to start thinking about subacromial impingement because it may happen once the scapula starts to work again. Thank you very much. We're going to change patient. This is a real case, and this is one of my own patients, a 62-year-old patient who retired, is not working anymore. His main concern is that he wants to play golf, competitive golf, and he has a subscapular tear when he was hitting a golf ball very heavily. So the first week he had a lot of pain, and when he came to me, a month had passed since trauma and a lot lower. He asked me, he told me that he wanted to wait for the season to finish until the end to have surgery.
He retired very early because he wants to play golf. He has an acute subscapularis tear. He was painful initially, but he's not so painful now. It's 3 or 4 weeks after the tear, and he asked me to wait to be repaired because he wants to finalize the season. So he's on season, and he asked me to wait for 5 or 6 months until the season ends. ¿Recomendaríais operar a este paciente o le diríais que hay que operarle ya?
Would you recommend operating? Would you say that you have to operate now, or would you allow them to wait 5-6 months?
I think that it goes one cuff on the front, and subscapular is totally critical. There will be an excess of external rotation, and there will be a deficit in the subscapular. So I wouldn't leave it. I think that subscapular is important in the operation of the shoulder. So I would operate as soon as possible. If the patient has a good subscapulary, I think that the patient can wait, because we have patients with a rupture on the upper portion of the capillaries, and then 3 months after, the patient is okay. The only problem is the biceps. If the bicep is medialized, then you have to operate, but afterwards. To me, this is not an emergency. The patient can continue for 3 or 4 months. I think that this is a professional patient. But if this were a competitive patient, I think this person can end the golf season and then have his operation. But the risk, as Philip indicated, is that there are subscapular that are massive, and then after 2 or 3 months, they become asymptomatic, and they are not losing their internal rotation strength because they have a good pectoral, and they can compensate it, and we can be wasting time, the ideal time, and it's not that the patient will come back to reoperate in 3 or 4 months. At any times, the patient is going to miss a competitive period because I think that if we go back to the beginning of the season, that the person will miss that part. It depends on the type of rupture. If it's on the upper part, I think that the functionality will persist. So the patient may have, if it's a complete rupture of the subscapular, even if the person wants that to end season, they need, if he may have a functional issue which may affect the mechanics of his golf swing, and I would bet on operating. Okay. And I left my friend Angel. He's almost as a professional. Well, of course, if I break my subscapular, then please, and it hurts a little bit, please wait. I will wait until the end of the season. I've had a lot of patients in my club, and this is this is a very good lesion in the subscapular and the anterior superior, but they have a very good clinical, and the outcomes have been good. I mean, I do the operation, and at the end of the season, they invite me for coffee. This patient had an operation, and then after surgery, as you can see, the patient is satisfied with the outcome, and the surgery did well. She had an operation in an acute phase. This is a 69-year-old patient, and they've had pain for 5 years, and then suddenly loses strength in her shoulder. She has signs of a deficit of strength and pain. No response to physiotherapy or to subacromial. This is the pre-op radiograph. Do you have any comments about this, Paolo? There is a little arthrosis, but I think the ascent of the humeral head is concerning because would you ask any additional images? You can have a contraction rate X-ray to see what's the reduction of the humeral head, and this could be more analog. You can get a better visualization, and then I would get a CT scan. Would you get an additional image? Yes, I would get a CT scan because this is not it is not focused. So in order for you to look at the distance, it is very hard to measure it.
Would you order anything additionally to this X-ray? MRI is useful because when you have superior migration, you have two tendon tear. If you have only one tendon, no superior. If you have two tendon tear, you have superior migration. And I think that is a typical case. She has before a supraspinatus tear a long time ago, 5 years, and now she has an extension of the tear
to infraspinatus.
It's classical case. I think that MRI is very useful to evaluate teres minor.
Francés y Ángel, ¿pediríais algo adicional aparte de una resonancia magnética o creéis que la prueba elegida? Ok, esta es la resonancia magnética.
So this is the MRI, and the patient has an increase of the humeral head. The patient has an important atrophy of the supras of spinous, and the infra and the three minor has been preserved. And the subscapular in this image, it is not seen very clear.
Am I right, Gus? Is that the subscapularis, supraspinatus, infraspinatus tear?
Yeah, the videos aren't running, but yes, with atrophy and infiltration.
Okay, so atrophy infiltration. Patient was 69 years old. Am I right?
Yeah.
So 69 years old. Un caso con atrofia, elevación de la cabeza del húmero.
So we have an atrophy case at elevation, and we have a rupture on the subscapular. What will be the approach in this case? There are lag signs, and in elevation, What will be the therapeutical? Pseudoparalysis is presented in this case, as Felipe indicated, these are patients that have these different situations, and the recent paralysis could be due to the subscapular rupture, or if we have it is different to have it for 2 years or 2 months. If it's 2 months, you can have a partial repair. So I think that the pseudo paralysis can be reverted. The patient has been suffering pain for 5 years, but all of a sudden she had a pseudo paralysis. So this is the sudden thing is quite recent. So this is, in my opinion, a possibility for repair. So you would do an arthroscopy reparation or repair or a better evaluation. The subscapular may be retracted in the cuts, and it's not, and it's more a medial. The image is not cool. We're looking just the axial. So I would ask for a better MRI to see, because it may be retracted, but it could be the subscapular, and with the graft and with the reconstruction of the spacer, the thickness, I think that she can recover mobility, and you can revert the recent pseudoparalysis. It's complicated. Well, this is a complicated case. I think that Guillermo's tip is really important, because in this regard, as indicated by Jen in the prior session, which has explained when there are certain lesions, when we have some irreparable, massive, based on the functionality, which is the most important thing. In this case, we need to face. We have a reverse arthroplasty. If the pseudoparalysis is recent, then I would also do an arthroscopy treatment with a partial repair, or an upper capsule and a repair. I'm sorry to disagree, but in 69, almost 70 years, if these, we all have patients that that if they're supraspinatus or infraspinatus, they may have I would try to do a conservative treatment. If it doesn't, and then if that doesn't work, have you tried physiotherapy? And they failed. She tried physiotherapy. The conservative treatment has been inefficient. So if there has been a correct physiotherapy treatment, and it does not, I'm not going to subject this patient to several surgeries. That would require a reverse treatment.
I think that in this situation, we have no arthritis. A good point is if you do X-rays, you pull the upper limb and you create a space. It's dynamic. Pseudoparalytic is not a static. And for me, this is a second criteria: dynamic and stability, vertical dynamic and stability. Okay. The third point is the quality of the subscapularis. It's the trophicity, because we know that the subscapularis, there is two parts, the inferior part, the superior part. If the trophicity is good, I agree with Guillermo to repair the subscapularis and to do a latissimus dorsi for augmentation. But if the subscapularis is not repairable and bad quality, I agree with reverse prosthesis.
We reverse. So you will first check the quality of the subscapularis, yes, on MRI, yes, and if it is good enough, you will try to do a repair, even though the patient is 69.
Yes, she's very active.
Yes, she's very active.
Woman.
She's very active.
69 is not old.
No, of course not. It's not. But of course. But we know that probably what Angel pointed is that reverse is highly predictable in these patients.
Yes. So yes, maybe the bed shot.
y si el problema es ese, ¿por qué no hacer una transferencia de un
And
latísimo?
then why not doing a latissimus dorsi transfer?
This is the first operation, and we
Correct.
know that the first operation, if you do a repair of the subscapularis and tendon transfer, is working well. After 2 or 3, no, I do reverse. It's a very important point for her.
Pablo, ¿querías añadir algo?
No, era ese comentario, creo que es.
It was
para mí
about the comment. To me, this is the patient. This is a patient to preserve the joint, perhaps a significant lesion if the subscapular is affected. And we were forgetting about the tendon transfers, which may also have a very good result in this type of the patient. This is something that has to be confirmed.
A repair, am I right?
I only heard part of what you said, but I thought it was a great discussion because I worry about these patients. I've done lat transfers, I've done repairs, we've augmented with biology, and they have failed. So I also worry about the complications with reverse arthroplasty. So this is a very difficult patient for me. I think all of the procedures that we've talked about can all work in some people. I don't know which one's going to work all the time. And I worry about doing a repair with transfer and then having it fail. And now the patient has to have another operation. So that was really the purpose to get all you guys discussing, what you would do and what your criteria. When the only question I have for you is when you talk to the patient about tendon transfer repair versus arthroplasty, what do you say or what advice do you give them based on the potential complication? Because the complications of a reverse are much worse than the complications of a failed repair.
Yeah, that's correct. But the major alternative that were discussed in the table in the session were repair versus reverse. I think probably I agree with you that the complications of reverse are potentially severe, probably, but this patient it has been suggested. We all know, guys, that you're highly experienced in the addition or the implementation of biologic systems like the clots, the blood clots for these patients. What was your experience in using this kind of biological augmentations in patients with a large rotator cuff tears, as in this case? Because this patient was not arthritic. So what would be your opinion on adding biologic stimulation to this tendon repair?
I would say in somebody with fatty atrophy and infiltration and a big retracted tear, we tried with the superior capsule reconstruction, augment that with biology, didn't feel it worked. If we were going to do a repair on this person, we would probably add it. With these massive tears. And the problem is as the group up there noted, had a long-standing supraspinatus and infraspinatus and the question would be, as you guys have talked about, repair with the failure rate versus arthroplasty in somebody with no arthritis.
Thank you, guys. There's a question to you from Guillermo.
I would like to ask a question. about latissimus dorsi transfer in this case to you, Gus, and then to Philippe. If you use the latissimus dorsi, you will use it external rotation around the humerus, or you just up to replace the subscapularis. You know what I mean?
I do know.
Because perhaps in this case, the line of pull is more important anteriorly than posteriorly to recover external rotation.
I have not had great results with latissimus dorsi transfer. To have a plastic surgeon come in with me as well, so that we could type of I'm trying to get coverage so that the pain goes away and they have functional motion.
Any comment on this, Philippe, please?
The goal of the latissimus dorsi is clear in this situation because you repair the subscapularis. If you are able to repair the subscapularis, you have to put down 1 or 2 millimeters the head to allow a good elevation with the deltoid. And the goal of the latissimus dorsi is to put to the posterior, to have external rotation in abduction. And there is no problem because you have a good teres minor. When in external rotation 1, you have good external rotation. The goal for her is to go down to avoid impingement and to have external rotation in abduction. And I do a latissimus dorsi classically described by Gerber a long time ago, but by arthroscopy now. And for me, it's a good indication. But if you are not able to repair the subscapularis, I don't do. Yes.
Thank you very much. Muchas gracias a todos. Tenemos que terminar nuestra sesión. Gracias a todos.
Thank you so much.
Bye, Gus.
Bye, Gus. Thank you very much for joining us.
Thank you.
Hey, thank you guys. I'm sorry I'm not there with you.
Thank you for the cases. Great cases.
Great
Thank
cases.
you very much.
Come.
Come to Colombia.
We're having great time here.
You'll miss it. Bye-bye. Thank you, my friend.
Muy buenos días a todos. Vamos a hacer la discusión de trabajos. Quisiera invitar a
Hey everybody, we're now going to study a few works. I'd like to invite Joaquín de la Paz
para que presente su trabajo predictibilidad e impacto
to
funcional de
show
la
his work on the functional impact of preoperative planning for the correction of arthroplasty in the rotator cuff.
Perfecto.
Buenos días a todos. A continuación, en conjunto con mi grupo, les vamos a presentar
Hello everybody, alongside my group we're going to show you the work that was previously introduced. We do not have any conflicts of interest as a form of introduction. When you have degenerative tears in rotator cuff, we know a number of things about them. We know they're a frequent pathology. In second place, we know that it increases with age, but we still do not know the real pathology. As time has passed, they have discarded a few theories, such as vascular theories and others.
se ha ido ganando importancia otras teorías
And other theories have gained importance, such as the scapular kinesia and also multiple factors as well at the biological level, so corticoids, tobacco, diabetes, etc.
la morfología
And we also
de
know that the morphology of the glenoid is going to have an effect here. We know that it is an acromial index, and the CSA angle also has an influence
del tobillo y por lo tanto va a traducir
indirectly on the vector, and therefore this will be translated in how there will be an overload on the rotator cuff and then increase the risk of tearing. As for the acromioplasty, we know that it is used quite frequently, but current evidence tends to demonstrate that its use can be questioned, its benefits can be questioned. The problem with this evidence is that techniques have been standardized and usually they're unplanned, and there are few studies on these kinds of acromioplasties that would lead to decompression instead of looking at the deltoid vector. The acromioplasty, the lateral acromioplasty, will have an influence on the ankle's vector and therefore on the angle of the rupture of the rotator cuff and the function of the shoulder, and therefore you can show that it can be planned.
del CSA,
You can plan the correction of the CSA, but the predictability of this planning has not been studied. Therefore, the objective of our research is to calculate the predictability of the correction of the CSA with lateral acromioplasty in patients that have had operations on their rotator cuff, and in secondary place to analyze the influence at the functional level on the outcomes. Functional outcomes. This is a prospective observational analytic study where we included patients above the age of 30 that have been subjected to degenerative tear repairs for the rotator cuff with a CSA of more than 35 degrees, excluding any patients who had trauma with unaltered CSA, with deformities or previous surgeries in the shoulder.
contó con aprobación del comité
This
ético
investigation, this research is approved by the ethical committee of the clinic. In the study, we performed a number of X-ray pre-operational studies. We looked at the CSA and we estimated the degree of correction at the lateral level to achieve a CSA of 35 degrees, and we also calculated the amount of degrees that we would correct. And then in the post-op X-ray, we also measured it in the same way. And we can see the CSA that we managed to correct. Based on these two values, we measure the percentage of correction of the CSA with regards to our prior planning, and we classify it as good, acceptable, or unsatisfactory, depending on whether there was a margin of error higher or lower than 25%, 50 or 75, 52, 75, or more. This is the technique that we used. At the lateral level, we create a mark with the arthroscopic reamer according to the estimate that was measured, and we also perform the lateral acromioplasty. All patients after 2 years had follow-up, clinical follow-up. We looked at the quick dash, the SSV, and the EVA, the analogous visual scale, and we subject these results to statistical analysis. As for the results, we include 41 shoulders in 40 patients, average age of 55.5 years, 23 women and 18 men, and average follow-up was performed 31 months later. As for the results of the CCA, we managed an average correction of 39.6 degrees to a CSA of 35.7, and this is just only 41% achieved lower than 35 degrees in the CSA, and 46% had unsatisfactory predictions of the correction. As for the function, we have good functional scores, and we did not, well, we found a surprise, meaning that there's a big significant difference between SSV and quick dash. Those who achieved CSA lower or equal to 35 degrees, they achieved better results.
De discusión respecto a la planificación
As for the discussion with regards to the right planning for CSAs, all patients achieved a reduction. Most of them had good predictability, or at least satisfactory or acceptable predictability, but 2 patients did not achieve CSA above 35%.
distribución estándar bastante elevada.
Predictability was unsatisfactory. Therefore, predictability is not great. The problem we believe occurs is that the X-rays, although they have been standardized, will alter the measurement of the CSA. And Gerber shows this in his original work. Some have proposed the use of a scanner, a CT scan, to measure the CSA. The other problem is that we don't know how posterior to go with the acromioplasty, the lateral acromioplasty. So this is underway, this work. It hasn't been done yet.
El problema
And it may respond to the problem through a standardization in the measurement of the correction. And finally, with regards to the function, this is the only study that assesses the function when you compare patients with lateral acromioplasty and without it, with standardized measurements, and they found that this has a significant influence on both core functions and also the variability of the tear. So as a conclusion, they managed to correct the CSA quite well, but you could improve functional scores. The predictability or pre-operational planning could be a useful tool, but it still needs to be developed. Thank you very much.
Muchas gracias por su presentación. Yo quería hacer una pregunta. ¿Tiene
Thank you very much for
estandarizado?
your presentation. I wanted to ask a question. Have you standardized the X-rays that you perform to measure the CSA angle? Because there's variation predictability depending on the angle of the X-ray. Can that change depending on the angle of the X-ray? If you can help me with the slides, there is a slide that has been hidden. That would answer your question, I think, about whether it has been standardized. Yes, is it standardized? Well, it is standardized, and we had an exclusion criteria when patients did not have a standardized measurement in the control.
quieres uno.
Okay, I have no more comments. Pablo, if you like, you can go ahead.
Sí, creo que este trabajo es muy interesante.
Yes, I think this is very interesting work. I would like to congratulate the entire group at the Clínica Alemana because they have given us teachings where we can introduce valid information and that we can take in a standardized manner in our practices on a daily basis. There is a serious problem here with this angle because the main promoter has been the European group led by Dr. Gerber. Nevertheless, this has not been possible to reproduce in literature, and only a few Asian groups are working on this. And I can very happily see that you are doing this too. So I think that this reinforces Dr. Gerber's concept. In my opinion, this is my personal opinion, I do not find a relationship there. I have never performed a lateral acromioplasty. I don't know whether you have experience with this. And this is performed only in cases where the acromial one is lesion due to flexion. I want to congratulate you, and I want to ask with which frequency you do this in your daily practices, and how do you standardize the lateral cut, and as you well said, up to which posterior point do you do this?
¿Aló? Ahí sí. Muchas gracias. Efectivamente, lo que estamos
Hello, thank you
haciendo
very much. Yes, effectively what we are doing now with all patients is that we repair the rotator cuff in the clinic. We measure preoperatively, and we also do planning in the correction with lateral acromioplasty in all patients, at least for small and medium tears. And with regards to how posterior we are going, this is still a question that we have not managed to answer. This is one of the alternatives that we found from a recent publication from 2020 that proposes a system that is a little bit more specific than our own. For planning, this is a little bit more tedious. Sorry to interrupt you, but due to the time, we have an important issue to look at now. Thank you very much for your contributions, and thank you very much. We will now continue with the next piece of work, which will be presented by Dr. Julio Armas from Tenotomy and Implants in Senior Citizens by Dr. Moreno. We just have 10 minutes of time to present this work. Tenotomy versus tenodesis of biceps without an implant that is fixed via arthroscopic means in senior citizens. Thank you. We are very thankful for the opportunity to participate in the event. I'd like to send you regards from Dr. Cho, who is the co-author of this work. This work is truly a small part of a larger piece of work that we have done, but we have tried to present this now. As a fundamental performance of a surgical technique that can help on many occasions. So whenever you do arthroscopic work on shoulders, you find pathologies, you find diseases. We do a number of tenotomies, and as a consequence of that, we cause residual pain with cables or contractions or previous lesions that we find. And so the aim of this technique is to perform tenodesis without having to use an implant. There is another objective too in this work, which is that it can serve as a rescue tool in the event that, when many of us have done tenodesis and the implant fails or it's ripped or there's a problem. I think this technique could help us solve the problem. The objective of this work is to determine whether there is a link between the tenotomy and tenodesis without an implant and their functional results. For this, we have included patients above the age of 65, for which we do simple arthroscopies in the shoulder to repair the rotator cuff and then find that there are tears or lesions in the biceps. So for one group, we perform tenotomies, and for the other group, we perform tenodesis without an implant, which is a technique that we have come here to describe today. We have assessed the results for this specific case based on the ASA scale, Popé, and other residual pain caused by tenotomy. For this surgical technique, we perform an arthroscopy as you would habitually in beach chair position. We look at the pathology and we do the tenotomy by inserting the biceps and labrum. Once we do this, we obtain the biceps through an independent portal at the suprapectoral level. Could you maybe continue with the video, please? Yes, there we go. Okay. So this is what we do. We cut the biceps at the proximal part, and we have a 1 centimeter cut that we do, leaving or conserving a proximal portion of about half a centimeter. Once we've done that, this is an arthroscopic portal. It's all done via arthroscopy. What we do here is that through that hole, through that incision, could you maybe put the video on, please? We have drilled already. We pass sutures from the distal to the proximal part. You can see the images and the photographs that we have on the right-hand side. And once we have gone through one of those, we come to the proximal part and leave a loop. Then we come back with the suture and go out through the distal part. So once we have come out of the distal part, this example is one that we use the procure for. So that needle that you can see in the last image in the distal part, we pass it through the center of the loop that we've left in the most proximal part. And once it's passed through, we leave the tendon aside. We forget about the tendon. What we do is measure the caliber of that tendon. And then we drill a hole. If you can continue with the video. We do this at the level of the humerus. This is done pectoral, and the assistant has to be very skilled, because with this instrument we introduce the biceps tendon within the hole. And once we put the biceps within the hole with an instrument that helps us lower the knot, we can start to push the structure and perform a knot that blocks itself. This way we can achieve the effect we can see in the last photograph on the part in the bottom. It becomes a little knot in the biceps tendon. So we secure that, we do knot after knot, and we make sure that its stability is adequate. We touch the tendon, and as you can see in the image, we prefer to have high resistance sutures rather than absorbable ones, but it doesn't look great, or it's not easy to see with a white fiber, so we've used a purple one. And once that's been fixed in, okay, we can see that it's being formed there. And another detail for this exercise, we use a wider bit, so you can see everything we're trying to do here. So our colleague here is just knotting it at the moment, and then he lets go of the biceps tendon, which is finally in its place. We can see that the biceps has been inserted in the area, and after this, what we do is make sure that it can be flexed and make sure that the tendon isn't moving, so we make sure that it's being fixed. We touch it and move it to make sure it's all in place. Okay, so finally, the results were rather encouraging. We found that there was statistical significance in favor of the tenodesis without an implant. We found that there was a better ASA scale score, and they obviously do have pain, EVA pain, almost at the same level. We believe that this technique has proved to date that we have good results in terms of the functional scale.
muy importante, ¿no?
And
O
also
sea,
another important point is that we have applied this on persons above the age of 65 and it works. So I think that the most important message here that we would like to transmit is that perhaps this surgical technique can serve as a rescue technique. So often implants fail and we're performing tendesis and the implant rips or tears. So this is a good alternative for us to solve things and solve these issues. So I think that over time we can continue to experiment in perhaps younger patients. Thank you very much.
Excelente trabajo, lo había visto.
I'd like to congratulate Dr. Armas and the group in Peru. This is excellent work. You sent it to Eckhart. I'd like to congratulate you. It's an excellent presentation with excellent images and the technique is very easy to reproduce. It's also cheap and easy to reproduce, and I hadn't actually seen the results before, the comparable results to the tenotomy in a very specific issue. So tenotomy in patients under 65, and I think that's the strength of the work and the results that you showed. I think this is a technique that we should consider and take into account. Why is it why can it be reproduced? Why is it useful? And according to the results that you show us in patients over the age of 65, you have the same results as the tenotomy, avoiding the pain and avoiding cramps and a good access value. So well done for that fantastic work for your group in Peru. Congratulations, doctor. Thank you very much. Okay, you were perfectly on time. Thank you very much. We're going to start the arthroscopy session, the second session at Slard. And for this, I'd like to introduce the moderator for today. He is a great friend from Peru, Christian Pasan. Welcome. Thank you for that introduction. Okay, we're going to continue given the time. And today we have our colleague from Professor Boileau from France.
Congress. He will talk about rotator cuff. Welcome, Pascal.
Can you hear me?
Yes.
Can you see my screen?
Sure.
All right. So thank you very much for this very kind invitation, and I'm sorry not to be in presence with you, but I think you've done a very nice meeting here. You've organized a very nice meeting. So my talk is to present to you in the next minute why tendon healing is important and the risk factor for failure of tendon healing, why I stopped doing the different type of double row or suture bridge cuff repair, why now I use for many years a double layer cuff repair instead, and how I perform this operation. I'm sorry. So what are the risk factors for failure of tendon healing? We know that the age of the patient is something important. The older the patient, the less chance of tendon healing we have, but also the tendon retraction. And we know that the more the tendon is retracted medially, the less the chances of having a tendon healing, of course. This is very obvious. Now, what is important and has not been very well explored, it is the fact that there is tendon delamination. And the first author to report this was David Sonaben, who just showed us that there were very often in those chronic cuff tears a superficial layer and also a deep layer. And this has been really been underestimated because the rate of tendon delamination in chronic cuff tears is between 40 and 70%. So we have done a study where we look at the influence of tendon delamination on rotator cuff healing. And this is what we found. We found that the rate of tendon delamination was increasing with the retraction of the cuff tear. You see 15% in small tear, 35% of tendon delamination in stage 2 medium-sized tear, and 38% in stage 3 retracted tears. So the more retraction, the more delamination you observe. This is the message. Now, this tendon delamination is underestimated, and we found that this has a negative impact on tendon healing. And the reason is very simple. The two layers are different in length and in direction of retraction. And I want to show you why I stopped doing those double row and suture bridge cuff repair, because I saw too many patients with this kind of failure after a cuff repair. You see the tendon is still inserted on the footprint laterally, but there is a medial necrosis of the tendon at the junction with the muscle. This is what has been called a type 2 failure. And this is after this kind of double row or transosseous equivalent cuff repairs. And what we see is that not only the tear is larger with more retraction, but also there is fatty infiltration of the muscle after this kind of type 2 failures. And double layer and double row are not the same. Double layer is, as you see on the left side, and double layer is what I want to show you now. It's completely different. So the reason I do this kind of operation of cuff repair is that you should read, and I think you read already the work of the Japanese colleagues, Mochizuki and Sugaya, who have shown clearly that there are two different layers of tissue on the footprint. One is the supraspinatus, and it's coming from anteromedial, and one is the infraspinatus together with the capsule, and it's coming from posteromedial. And you see the direction is completely different. When there is a tear initially anterior, and it's only the supraspinatus, the retraction is medially and anteriorly at the base of the coracoid process. When the tear extends to the infraspinatus, which is the deep layer, then there is a retraction which is going posterior to the glenoid. And so the deep layer is in fact the infraspinatus together with the capsule. So each time you see a delaminated tear, cuff tear, you know that it's both the supra and the infraspinatus tendon together, which are retracted. So the deep layer is going posterior-medial, while the superficial layer is going anteromedial, as I said. So as the direction of retraction is different for these two layers of tissue, and as the length of retraction is different, there should be different site of reinsertion. And this is why we do this kind of repair, because each layer are repaired separately in order to perform an anatomic and balanced cuff repair. So the deep layer is going medial, it's fixed first with a loop suture, and the superficial layer is fixed in a second step, and it is going lateral to the footprint on the greater tuberosity, and this is a tension band repair. So this is the way I do this kind of operation. You see, this is a delaminated tear here. The footprint has been abraded already. The anterior part of the shoulder is on your right-hand side. You can see the biceps more medially. So we put an anchor here close to the cartilage and posterior to the groove, to the bicipital groove. We have done the release of the tendon already with capsulotomy superiorly and with opening of the rotator interval. And as you see, we have two sutures. We take one suture with a loop here that goes more anterior here. And then we take the second suture and we're going to catch the deep layer again with a hook like this. And this tissue is very thick because it's both the infraspinatus tendon and the capsule together. We make a loop. We catch the opposite strand of sutures, and here we can bring from posterior and from medial the deep layer, which is in fact, as I told you already, the capsule together with the infraspinatus. And you don't need to bring it lateral to the footprint, you just put it medial to the footprint with these two loop sutures. And now it becomes very easy to repair the superficial layer. So in this case, we're going to put two anchors with 4 sutures because it's a pretty large tear. And we go posterior to the groove where the bone is hard here. We catch the tendon here. We use a hook here to pass a PDS suture, which is a shuttle, which is used as a shuttle. and we bring the first tension band sutures on the superficial layer of the cuff. And you see that there is no tension anymore since the deep layer has been repaired. So the tension band suture here will just bring back the tissue on the footprint very nicely, and this is compressed by the reverse mattress stitch. Here, since the tear was going more anteriorly, we do another stitch more anterior, which is taking also the rotatory interval and part of the subscapularis in the front. And this is the second tension band suture here. And now we go posterior, and we take the superficial layer more posteriorly here. Again, we repeat the same movement with using a PDS as a shuttle, and we tied those tension band sutures. So this is a tear where we have 4 tension band sutures here with 2 anchors lateral and 1 anchor with 2 suture loop medially. You see, this is the rotatory interval which is open here. This is the final aspect with a complete repair without undue tension, which is the most important to us for having a tendon healing. So in summary, this is my message to you. The tendon delamination in chronic cuff tears has really been underestimated. This delamination of the tendon has a negative impact on tendon healing. The more delamination you have, the lower the chances of healing. And if you understand that these 2 layers of tissue have different lengths of retraction and different direction of retraction, then it's easy for you to understand that you should have a separate fixation of these 2 layers of tissue. And again, the infraspinatus is going posterior medial with the capsule, while the supraspinatus is going anterior medial in direction of the base of the coracoid. You see one case here with a final aspect at 6 months with the double layer cuff repair. You see that the tendon is completely healed on the footprint, and you see the nice healing of this patient. We have done a series where we have 97% of tendon healing by doing this technique. And again, what is important is that you cannot bring the whole tissue, the 2 layers of tissue, with the same sutures at the same location, because anatomically they are not supposed to be at the same location. For us, double row or suture bridge are not used anymore. We don't want to be in trouble. We don't want to harm patients. We don't want to have a bigger tear, and we don't want to have a fatty infiltration of the muscle. And this is our indications today. If it's a small tear, very little retraction, stage 1 with no delamination, which it means it's an isolated supraspinatus tear, we just do a tension band cuff repair. That's enough. We have really show our results. Now, if it's a stage 2 or 3 retraction with a tendon delamination, it means it's a supraspinatus plus the infraspinatus tear, then we do a double layer cuff repair. Thank you very much for your attention. And we hope to see you soon in next June in Nice for the knee shoulder course on June 9 and 11. Thank you very much.
Thank you, Professor Pascal, for your lecture. Vamos a continuar con la siguiente charla que está a cargo del doctor Francis Soler. Él nos va a hablar sobre ahora en pacientes jóvenes.
Buenos días. En primer lugar, agradecer, como no, la amable invitación del Comité de Hombro de Slard por dejarme compartir con ustedes nuestra experiencia, nuestro conocimiento en este tema que es tan sugerente. Si no dejo de compartir y vuelvo a compartir. 2 minutos y solucionamos el problema. Como iba diciendo, el abordaje de las lesiones, el manguito rotador en pacientes jóvenes.
Okay, Professor Pascal, would you stop sharing your screen, please?
Fantástico, gracias, muy amables. Como iba diciendo en la introducción, el abordaje de las lesiones del mango rotador en pacientes jóvenes es todo un reto, porque precisamente por las expectativas. Es decir, para mí esta slide es posiblemente la más importante de la charla. Es decir, pacientes jóvenes, las expectativas de funcionalidad de la articulación del hombro son absolutamente diferentes a las expectativas que pueda tener una persona ya no tan joven, ya no pongamos de edad, pero con unas necesidades funcionales mucho más limitadas. Entonces, aquí nos tenemos que centrar muchísimo en las expectativas del paciente, en qué espera el paciente de nuestra reparación, de nuestro tratamiento, en base a cubrir sus necesidades. No olvidemos, centrados en un entorno muy específico, que es el paciente joven. A partir de aquí, las roturas del mango rotador. Bien, nos tenemos que ir a lo básico, a ciencias básicas y saber que ya hace años, estos son estudios de los años 90 del siglo pasado, que ya definían que difícilmente lo que es una rotura parcial se soluciona espontáneamente. Es decir, la historia natural de las roturas del mango rotador son hacia un empeoramiento, una evolución hacia ir a peor. En un paciente joven, cuando tenemos una rotura parcial, es importante tratarla. Es importante tratarla porque si no sabemos que, tal como en este estudio ya se publicó y que refrenda los estudios de los años 90, hasta más de un 30% de las roturas parciales pueden evolucionar a roturas completas. Entonces, cuando las detectamos, a pasar las roturas parciales muchas veces no se detectan, porque clínicamente pueden simular una situación de inflamación del mango rotador, pero cuando las detectamos, las diagnosticamos o en el acto quirúrgico las observamos, las tenemos que intentar tratar según la técnica y el conocimiento y la habilidad de cada uno de nosotros. Esto nos ha hecho de que hayan aparecido algoritmos de tratamiento de las roturas parciales, según el grosor de la rotura, la regla del 50%, menos del 50%, más del 50% del grosor del tendón de la rotura parcial, un abordaje de desbridamiento, un abordaje de reparación, sea completando la rotura o sea la rotura parcial. Este trabajo de hace 4 años ya nos indicaba que la evolución natural de las roturas del mango rotador era hacia a empeorar. Es decir, las roturas parciales evolucionan a roturas completas y las roturas completas van aumentando de tamaño. Sobre todo en un paciente joven, cuando diagnostiquemos una rotura ya no parcial, sino completa, pero de pequeño tamaño, tenemos que repararla para evitar precisamente la historia natural de esta rotura y la evolución hacia una mayor complejidad. Es decir, roturas de pequeño y mediano tamaño en pacientes jóvenes con una demanda física a nivel medio o a nivel alto, no dudemos en reparar estas roturas. ¿Por qué? Porque reparar estas roturas, tal como he dicho en la charla anterior en la mesa de Isacos, nos permiten que la capacidad biológica y la capacidad de reparabilidad del tendón sea mucho mejor. Y esto es el éxito o el fracaso de la
So
cirugía.
this involves the success or the failure of the surgery. Why? Because that's where when we have a problem, a young patient with a high functional demand that coming for consultation with this type of situation, this is the problem that we need to avoid. We may have the situation for the first time because there's a field rupture, massive retracted without the repairability, where there was a compensation, and there's decompensation, and there's a functional and a painful limitation of this elbow. This is the problem that we need to avoid, because this is truly a problem. When we do the arthroscopy, we have a retracted tendon without any repair possibility. When we have a young patient with high or medium functional demand, so what can we do in these cases? Why not? We could do a conservative treatment. I go to the first slide based on the expectations of the patient, but we need to suggest a conservative treatment. Why? Because there's a certain capacity for improvement. But in a young patient with a conservative treatment, we can improve the pain, but there may be some functionality problems. And there's where we have the expectations. At this time, we can get some rest, but when I try to do my usual work, then this elbow is not working. This shoulder is not working. And this concept, the functional irreparable rotator cuff tear, this was led in Mayo Clinic, and this is where they defined this problem. So we were having an irreparable rupture of a rotator cuff, which was working, but there were some limitations. So how can we treat this? These authors were defining a downgrading of the treatment, which we have assumed, which is the partial repair of the rotator cuff, the tendon transfers, and the reverse prosthesis. The partial repair of the cuff, it could work well, and in young patients, we should try it. We should try it because then they can actually provide promising results. In this study, this is a study that is very interesting. This is the group of from Greece. So if you look at the latest information, the partial ruptures at the level of repairability have a high failure rate, almost half of the cases, but are indicating this is applies to the balloon. This was the first publication, but an easy option, and the studies, prospective studies, have demonstrated that in those cases where we have indicates that the treatment of new sutures in rear tiers of the rotator cuff will add, and the results are also promising. This is an interesting study published 4 years ago, comparing both techniques with the balloon and the superior subacromial. There were no differences. An operating subscapular, which is not a pseudoparalytic shoulder. Why do these techniques operate? In my opinion, is that these techniques are useful so that what brings back functionality to the shoulder is to work on a scapulothoracic articulation. These spaces allow reducing or augment the subacromial space, so we defend the humeral head, increasing the vector of strength of the deltoid, and together working with the scapulothoracic articulation or joint allows us to improve the functionality of this shoulder. But if we don't have an adequate work, then the outcomes are not going to be. The tendon transfers, I'm not going to talk about the detail. This morning we heard Dr. Giancani, and he explained, he gave us a whole lecture about the different techniques for these type of transfers, their indications, and when to do each one of them. And for young patients with massive tears that are not that irreparable, these are just the few options that we have to recover some strength. And evidently, the last option is that we should not use it logically, because the indication is for older patients. For younger patients in the rotator cuff, we would try to avoid this type of reverse prosthesis. And to finish my participation, going back to the article of the Mayo Clinic, they were suggesting this treatment algorithm that if we look at it in detail for patients where the failure rate with a failure in the conservative treatment with high demand, that would be the part on the right of the algorithm. They only talk about the tendon transfers. Thank you so much for your attention. Thank you, Professor Soler. We're going to have Dr. Giancani with bicep tendinosis. How do I do it?
¿Es posible el láser, por favor? Yes, yes. My talk will be the biceps tenodesis, and I will show you the result of an implant-free technique. So the keyhole technique. But before talking about that, thank you very much, my friend. When we discuss about tenotomy, sorry, I think one is. Yes. What are the options? Of course, just to sum up, you have tenotomy and tenodesis, and the tenotomy can be made with different techniques, simple or with a wedge shape. And tenodesis, to sum up, you have the lasso loop, the interval screw, and you have the keyhole technique. These are the published technique. And you can do both of these technique, all these technique, either suprapectoral or subpectoral, either open or arthroscopic. So first of all, the tenotomy, you know the limit and the drawback. The problem is the Popeye syndrome. And in fact, to prevent the Popeye syndrome, a very easy technique is the wedge osteotomy. So you cut a larger piece of the rim to have a very thick biceps, and it will lock itself into its groove. But the problem is you need a good cuff. Because you have no cuff, this technique cannot work. It will slide very distally. And the other problem is what about the hourglass biceps? When you have a very big biceps, if you cut the biceps, it will not slide. You have to excise part of the biceps, and then it will slide very distally. So the tenotomy alone cannot work every time. for every patient. You know, of course, the lasso loop described by especially Laurent Lafosse, there are also limits and drawback. For example, if you have no cuff tear, you have a slap lesion and you want to make a tenodesis with a lasso loop, you have to cut the bicep. Of course, it's very easy, but if you want to fix it with an anchor, you have to go through the cuff and you have to damage somewhere the cuff. And I'm not sure when the cuff is normal, when you have a slap lesion and you want to treat it with, I'm not sure the lasso loop is the best technique because for me, little invasive. Finally, Pascal, Philippe Valentin and Pascal Balotou, they describe the screws, interferon screws. You know perfectly this technique, but you have high risk of rupture, not because it's a weak technique. Of course, it's the strongest one you are going to see, but the tendon can slip or it can split onto the bone, and you can see this angle between the bone and the tendon and the screw is a 90-degree angle, and this could create a failure, problem with the tendon. It's expensive, and you need an instrumentation. So in my technique, and you have published this paper with metallic markers onto the tendon, we have 11% of failure. So it's an objective study because we have implanted again metallic marker landmarks inside. So there is the subpectoral tenodesis, and what are the limits and the drawback? Of course, you have to make a mini-open technique. So when you do an arthroscopic surgery, so it's not very nice to make a mini-open technique, and you have to do it after the arthroscopy. So you have to making first an arthroscopy, you cut your bicep, then you go here to look for your tendon, but you have a swelling shoulder because imagine you have to repair your cuff. So after half an hour, 1 hour, you have a swelling shoulder, then you have to open and to make this technique. It's not for me a very nice technique, but it could be a great technique if the bicep is already ruptured. Of course, then you just have to open and to fix it. Why not? But finally, I've described the keyhole technique, and it's very similar than the previous presentation of our colleague from Peru. Freudenson, this American guy, in 1975, had published the keyhole technique with an open procedure, and probably you know this one. So I've just switched this technique under an arthroscopic technique, and you can see what happened here. So you go under the pec major, then you open the bicipital groove, and even if there is no cuff tear, you can go there, you cut the biceps at this glenoid insertion, then you open the bicipital groove, and you prepare the bone, and you are looking for what I call the half pipe area. And so most of the time onto this half pipe, you have an osteophyte, and which would create why you have some biceps, long-head bicep abrasion. Then you use a very simple drill. You penetrate through the head, not through the head, but through the metaphysis, and you cross the arm. You have no risk of having a nerve injury because I've never had that. You drill 3 centimeters of deepness and a drill of 7 millimeters, and with a ronger, you make a keyhole, you shape a keyhole, and it's very easy because it is an automatic fixation. You will see the tendon coming inside. You can see that you double the diameter, then it's very big. You pull it, then you penetrate inside, and of course, as you will see, it's a self-locking system without any implant, and it is less than 10-minute procedures, and you can see here what happens. So at it's very big, you penetrate through the 7 millimeters hole, and then it's located because you have made and shaped a keyhole technique. And what happened? So the problem of the keyhole technique or such a technique, implant-free, have been analyzed, and you can see here this mechanical study, biomechanical study. They've shown that the keyhole is the weakest technique. I said yes, it is the weakest technique of all the technique, and the strongest one is the interferon screw. But this has been done in a cadaver lab, so you know that the cadaver lab is not the. And I've published these 3 papers, so you can read it. And again, as you can see, I've put some metallic marker inside into the tendon. and you realize that with the keyhole technique, you only have 3% of failures, but with the screw, with the intervention screw, you have 11% of failure. So even if the biomechanical study have proven that because technique in the real life, it's not the case, it's not the same result, and we have to consider that. So in conclusion, yes, I do this technique, it's implant-free, and for me, I only see advantages. Thank you very much.
Thank you, Professor Cani, for your lecture. A continuación tenemos al doctor Mario Larraín de
We now
Argentina.
have Dr. from Argentina who's going to talk about repairing the rotator cuff with double row sutures. Hello, good afternoon. Thank you to the committee for the invitation. It is a pleasure to be here with you and share this table with you. The best results in the repairs of the rotator cuff have been seen in the healing, and this really depends on different factors such as the age, the quality of the tissue, the size of the lesion, its configuration, retraction, and fat degeneration, etc. We need to understand the anatomy of the person and the different concepts about the insertion of the rotator cuff. It is evident here that the surface of contact with the double row technique will be the closest to the transosseous equivalent that could cover 100% of the blueprint footprint. The double row suture in this sense would be connected via bridges, meaning that it would have better coverage of the insertion surface, would increase resistance, and it has less movement on rotational force. This biomechanical work shows that the resistance and the strength and the coverage of double row repairs was higher and better than single row. So when the tendon is not in the area that we want to reach, we obviously have to perform a release. And so the idea is to have points of convergence. We need to be careful, or a margin of convergence. We need to make sure we use this in the right cases. So we need to discern the type of lesion, the pattern for the reduction of the lesion. Otherwise, these points of convergence can really limit us when we are moving the rotator cuff and make things difficult where we really want to insert it. So it's fundamental to acknowledge the pattern and the pattern for the reduction of the lesion as well. The key for success is to acknowledge the pattern of this lesion, the appropriate release without damaging the tendon and the structures. The blood fill is very important as well, and debridement, because we need a favorable scenario for healing, and the improvement of the same can be achieved through microfractures that will improve scarring with the arrival in the area of stem cells that will improve our healing process. It needs to be fixed safely with minimal tension. It needs to cover the footprint really well, and it's fundamental also to ensure that you have adequate rehabilitation, to have progressive mobility without producing a tear in the recovery phase. These, in this particular case,
Perdón, ¿cómo hago para ir para atrás?
sorry, how do I move back?
Ahí está.
There we go.
Bueno, está bien. La doble fila, gracias. La podemos
Okay, good. So double row sutures can be used with the bridges, with bridge sutures that can be crossed or not. We saw a bridge suture that was direct without the crossing. And in this particular case, where we are using the first row here, it's done at the osteochondral union. So because it's the best pull-out region, we like to add sutures and knots in that area because we think it's very important to ensure that the rotator cuff contracts well in that area because it's going to be the strongest and it's where we're going to have better resistance. The lateral area is an area that we always look for by crossing the sutures with an anchor without sutures. And we can see what the reconstruction looks like here and whether we need more anchorage in the anterior or posterior regions. The bridge sutures tend to better preserve the repair, and we have to be really careful about where we place the first row and where we put the first stitches, because we may invade the myotendinous union. We need to leave 2 or 3 millimeters there because otherwise re-tears occur in this particular situation. They're very difficult to solve. These studies show, well, you can't see the bottom of the slide, but they show that there are some meta-analyses that talk about levels 1, 2, and 3 of studies. And in a subgroup of patients that have lesions under 3 centimeters in terms of the extension, there are no clinical or hemological differences when you look at first row or single row versus double row. But when you look at lesions above 3 centimeters or greater than 3 centimeters, differences are statistically significant. There are improved clinical results, better ASIS and UPLA scales, and better healing when you look at the imaging and more stabilization with double row sutures. The study by Gassman also shows us a comparison of 50 cases with double row and single row that has better healing in the control group with an ultrasound for double row. But it's always very important to understand that there must be a remaining tendon of more than 1 centimeter, and this justifies double row. If there's a kind of remnant of a tendon that is lower than 1 millimeter, then it doesn't make sense to try that. This is a study that shows that the level of healing is significantly better in large tears with double row compared to single row. Nevertheless, we do need to consider that the suture bridge, the original one, has 2 anchors and 2 laterals, but we need to add, or we can add more anchors and more sutures in the lateral sense because there are no clinical differences or differences in the results when you compare 1 anchor or 2 anchors in the lateral row. When it comes to repairs, double row repairs, we studied that in the immediate post-operative stage, so the first 2 months, pain is greater in double row repairs, but when you look at that phase about a year later, it is significantly lower. The residual pain is significantly lower when it is a double row suture. This is a special case, a highly competitive rugby player with instability, a Bankart lesion, and a significant lesion in the rotator cuff, these patients have instability, which isn't too significant, but it's painful. We've seen this in a number of situations. And in these cases, we often see partial lesions that we call massive partial lesions, where basically the entire surface, the extension of the rotator cuff is exposed. In these cases, what we preach and what we believe is the best is to stabilize the shoulder, repair the subscapular, see what to do with the biceps as well. And that's what we're doing here in this area. In this case, Jacques had a tenotomy without Pompeii. So we repaired the subscapular, and in this case, we did a double row repair with trans-tendon anchors. So in these large lesions that are partial but also quite extensive, in these kinds of sports persons, there is a good quality of tendon. So it's best to work in this area instead of breaking it to, or rather tearing it to create a complete lesion. In conclusion, each case should be personalized depending on the patient, the age, prior studies, and fundamentally as well, the assessment of the pattern of the reduction of the intraoperatory lesion. Double row repairs is biomechanically superior. The bridge suture technique better reestablishes the contact surface between the tendon and the bone, and lesions above 3 centimeters. Within these, you can see significantly better results from the clinical point of view, as well as in imagery, and with a lower index of tears in double row repairs. Thank you very much.
Gracias, Mario. Excelente tu presentación.
Thank you, Mario. That was an excellent presentation. We will now listen to Dr. Alejandro Jaramillo, who is going to talk about his experience in the use of PRP. Go ahead, Alejandro.
Muchísimas gracias.
Okay, good afternoon. Thank you very much for inviting me. It is an honor for me to be here sharing my talk with a very important group of panelists, and this is the topic for today: PRP in the rotator cuff, should it be used? First of all, I have no conflict of interests. At the moment, I have not added any plates in the rotator cuff. When we started the talk, I was more on the skeptic side, and then as I started to look at the technology and what it says and how it works, and how it can, we can see how it can include improvements, but these platelets are filled with growth factors, so 13 approximately. These are the most important ones: insulin, fibroblasts, and others. And when we start to perform research, I think, or when we start to look, there are studies about PRP being included in hair and also testicles and other places, and I found type 1 evidence in other tissues for bone remodeling, also for healing, excellent results in nerve regeneration, diabetic ulcers as well, a lot of work there with great results, alopecia, and androgenic alopecia for those of us who are starting on this path, and also acne scarring. So great work has been done with great follow-up with meta-analysis and type 1 evidence. So this started to open a path for me. We have low biology rotator cuffs in which this has been used. Let's see what we can find. This is perhaps for me the most important slide because it shows us both sides. So PRP creates tenocytes. So the raw material is there, but it doesn't create collagen. So it makes us happy but sad at the first time. So we do have the raw material there. something is produced, but the configuration or the meshing of these tenocytes does not produce tissue. So optimists can say that something is produced, but pessimists can say, well, actually nothing that works is produced. This is why it caught my eye. Part of the problem, we are talking about many different things, many different types of work. Everybody wants to innovate in a different way, and finding a standardization of the technique or homogeneity in the type of lesion that is treated and the concentration of leukocytes and the way that they are prepared and is still not there. This really limits our results when we perform these kinds of studies. So what I wanted to find is what kind of study can shed light on these pathologies that are daily pathologies, so partial tears, tendinopathy with of different types, so massive tears and others. So this is what I wanted to resolve, whether it works in partial ones, in tendinopathies, according to the evidence found between 2018 and today. There are many publications, few of them have significant statistical power. 745 pieces of work in tendinopathy, only 5 of them comply with all of these processes. They are compared to PRP, dry needle, placebos, physiotherapy and others. We also find results here in pain and functional results with the scales, and there is truly no statistically significant difference here in terms of the pain and also the function. But after 6 months, it's not any better than physiotherapy. So in tendinopathy, we did not find that the PRP can be justified or its use can be justified. Then we move on to partial tears and PRP, and it's the same. So there are multiple pieces of work, only 13 of those have significant power to really assess this, and there are both chronicle and acute for the results. And for those who are acute, those with PRP are much better, they're doing much better. But after 6 months, with these kinds of partial tears, there is no difference in the use. So this gathers lots of different articles together, and they look at progression. It doesn't improve functionality or pain scores, but perhaps they will not progress, and the result is that it does not limit the progression of the disease or the onset of the disease. So this is another comparison. Poor leukocytes, 1,500 RPM, sodium citrate, 80% platelets. Initially, PRP is better, but then after that, it's pretty much the same. So these results, for them to be optimistic, can be seen from different perspectives. Those of you who are pessimists can see it in a different way. This is a very optimistic comment because it says, okay, we have reached good results, the good results achieved by steroids without the secondary effects. Or the side effects of steroids. So we'd need to look at re-tears due to the prior use of corticoids that may make it cost effective to use PRP, but this is a response that is yet to be defined. So if you want to look at the positive side, it does have its advantages, but is not better than steroids in the studies. In terms of complete tears in PRP, there are more or less 15 studies that are quite valid, 13 to 15, and results depend on the study that you look at. So first of all, you have to define whether these platelets have low leukocyte counts and or those that are rich in leukocytes. Those with low leukocytes reduce the re-tear rate. It reduces the incomplete healing rate, but when you compare end results, there is not really a statistically significant difference. But what the work shows is that PRP should be placed under leukocytes. This is the result of randomized studies where they compare results of PRP versus non-PRP, less pain in the short term, and it produces re-tear rates in the mid and long term with good type 2 evidence if we compare it to when it is not used. This is another piece of work where they also show that re-tear rates reduce. There are better UCLA scores with analogous visual scales. And there's another piece of work that starts to look at differences between types of surgeries. And they show when you use single row for PRP, there is a statistical difference in retears in the future, but this difference is not present with double row. So for people who use single row, maybe that biological reinforcement could provide better results. But for those of you who use double row, you have that mechanical support, so possibly you do not require the use of PRP. There are no studies to discriminate massive tears or to divide massive tears. I think there's another issue here. For those of you who like cells, the sentinel cells do better than platelets in these kind of tears, the evidence suggests, but the biggest evidence of the massive tears lies in the scaffold. So we should start thinking about filling holes with low pressure or low tension instead of thinking PRP is going to solve a content issue. This is an invitation for people who publish so that they can follow certain standards in the literature in order to be able to define what kind of PRP to use when it would be used to have certain results, clear results in literature. In terms of the fat degeneration, we have made great progress to understand why apoptosis has scenarios where fat degenerates, but this is still unclear in terms of management, and perhaps the improvement in these types of tissues is linked or does better with stem cells than PRP. So this is the target set out by researchers, but there's not really any information about that yet. This is a kind of summary because we need to think about cost effectiveness as well. It's not been approved by the FDA. They do say that it can have beneficial effects, but efficacy at this moment has not been demonstrated. So this is what I wanted to show you from the beginning. For tendinopathy, I would say that PRP has not proved to be statistically significant for partial tears. This is not any better than steroids, and it does not reduce retear rate for complete tears. We would use single row, but it has not been indicated for double row. For massive ruptures, massive tears, it's the same. So single row and perhaps biological stimulation can help, but if there is a double row, that may not help. And I think the take-home message is we shouldn't think about biological PRP, but rather a different type of stimulation, such as patches and scaffolds. Or for fatty degeneration, PRP definitely doesn't work. And I think the war has caught my eye. The message of the president of Ukraine, who said, "Don't put up my picture where people make political decisions. Put up a picture of your own family and you will make better decisions." So I think that we should always take into account the people we love and say, I would give you PRP, I would invest in that, I definitely would, and that will make your results better. So at the moment, with the evidence, I think a great window for the future has been opened, but we still need to wait for results. Those who use single row PRP, I think, would have the backup from the evidence. Thank you very much. Thank you for your interesting review, Alejandro. We will now listen to Ángel Calvo, who's going to share a few clinical cases. Go ahead, Ángel, please. Thank you very much, Christian. The panelists are invited to come to the front. Ying, please. Emilio. Francis. I have prepared a few, but I want to focus on one to be able to express and really get the most out of everything that this could help us. This is a male. He is 66 years old. He's a sports freak. He does all the sports you can imagine: tennis, paddle golf, ski, rowing, canoeing, swimming, sailing. windsurf, kitesurf, and he has a traumatic dislocation of the shoulder. And also something dangerous in his background is that he is a cardiac surgeon at a hospital in Spain. What can we conclude from this initial X-ray, Francis? You are closer. That this patient does not work because he has time to do all of these sports, so he must not work. Yes, because he's a cardiac surgeon, heart surgeon. My first conclusion is that he does not operate, or maybe his day is 48 days long, who knows? Okay, possibly he already had a prior tear that evolved for quite some time, which allowed him to perform these activities. I would conclude with an MRI to better establish. Okay, we have an MRI here for Mr. Mario.
Explícala tú, lo que ves.
So if you like, you can explain what you can see there. There is a massive tear here with an elevated head for the rotator cuff. I can't quite see whether, well, it seems they don't have a Bankart lesion. I can't quite see the subscapular here. He doesn't have one. He has a fibrous part here, but there's a tear in the subscapular. Here we can see that there are already some structural lesions from arthrosis. What do we do for this patient? He is used to doing all kinds of sports. I think this patient needs surgery due to his activities and age. Maybe we should try to perform an arthroscopic repair. Of what? I saw the supra, the infra, the subscapular all torn.
Cuff tear. It's Amada stage 3, so there is nitritis, but this was before the trauma. And as this shoulder was really functional before the trauma, probably now it is pseudoparalytic, and there is an acute tear, I think, an acute tear of the subscapularis, but a chronicle and old tear of the supra and maybe infraspinatus, because at the MRI on the T1, we can see fatty infiltration of the supra muscle belly. So that means it's an emergency for surgery, to go to surgery, to repair au minimum the subscap, just to rebalance the shoulder, to recover the shoulder before the trauma.
Ahora voy a enseñarlo. Claro, este es un cirujano y en su hospital, los médicos de su
This is the
hospital.
surgeon, and the doctors tried to be as careful as they could with this patient. And the report and the discharge report, they said that they did a infraspinatus repair and acromyoplasty. And what I would like to add in this case is that in the case of instability, if we do not repair the subscapular, they're going to keep on using it. And I think that this is an indication that is really important. Yes, I like that proposal, but this is what you need to do in order, but look what he had to do in order to live I know that there is a elevation, but there is an anterior situation that is quite relevant. This, in addition to the fact that there's another situation, and it's the fact that there's a deltoid, a prior deltoid effect. And in this situation, what can we do in this case? So should we apply a conservative treatment? I don't think you will disagree. There is a very severe problem for the regular function in SCR. Could this be possible? Do you have any images after the surgery? Didier, And I think this got things worse. And then after he was operated, he was seen 6 months after. Then in this case, we need to determine if there's a deltoid, it is for a it's a post surgery. Okay, so it is important to know what will be the future of the deltoid, because it's going to yes, I fully agree with you. For the first time ever. How about the trial? I think that this is a major technique for disability.
For me, it's a clear combined loss of elevation and internal rotation after the trauma. So he has been repaired correctly posteriorly, but he has a gap into the deltoid because of mini open, and I think there is no subscap. So it is the limit to the cerebral shoulder and limit to the tendon transfer. But we could try after 6 months. I think he will not improve probably. So we could try an anterior arthroscopic latissimus dorsi tendon transfer to try to balance the shoulder. And if it's failed, yes, there is no option than a reverse for me.
LTT is your choice.
My choice?
Yes.
First, lat dorsi transfer anterior to the subscap. My first choice.
Okay. El balón no tiene ningún sentido aquí, no.
Balloon makes no sense, and a reverse prosthesis, the patient will say that they do not want it because he cannot do his activity, and for him, that's the fundamental thing in his life. Okay. So this was my attitude. So I divided the intervention in 3 parts. One was an SCR and then to do the subscapular repair. It was a repair negotiated with the patient because he wanted to do his sport with a certain regularity. So the subscapular repair, it was open because I had to reconstruct the deltoid, which was the 3rd part. And what we did was a surgery. We did an SCR, a subscapular, and the deltoid. The deltoid reconstruction to me is extremely difficult. I used the whole tissue that I could, but I think that these are the implants that we used first, and the SCR I used it to reduce the deltoid. If there's a rehabilitation program, I think that this man is doing a lot of efforts to improve his situation, but at least they could be sufficient. This is the situation of this man 6 months after, where he went back to his activities. But I am not confident that this is going to do well. I really don't think that this is going to be. I don't think that there will be a happy ending in this case. I'm sure that you may have had a conversation with him, lowering the expectations. That's really useful. I mean, I have a question, Angel. And this patient, given his age, the type of lesion, it is not justifiable to determine what was the lesion with instability. But if this were a younger patient with this type of sport, in those cases, we would stabilize this patient. Yes, that's one of the options, because you're there and this is something that you can treat. But the problem was not the instability. The thing is that he doesn't have a shoulder, basically. So what I want to convey, especially to the young doctors, where was the error here? What was the error? I think that the initial error is not being initially assessed. Despite all the love he was given, he was treated as if it was an acute cough tear. And the thing is that there was a decompensation. He has been operated for the past 2 years and has not been back yet. But the situation 6 months after, this was the situation. So we do have a better subscapular, but the rest of it is the same. And it's really scary. I mean, the ocrium, he's missing half of the cranium. And in the repair of the subscapular, was it easy, or did it look like a rupture? But what can we do? Did we have to do anything to the cranium?
For me to follow.
Do you think that you need to do something to the acromion?
To the
Because the
acromion?
acromioplasty is a half of it.
Sorry, I didn't see acromion.
You was sleeping.
No, I was not sleeping, but I was looking something else because your question was what was the mistake. So I understand what is the mistake, because at the end the result is not so bad.
No, the mistake at the beginning. And
Yes,
the first treatment.
at the mistake at the beginning, I think it was because the subcat has not been repaired. This is the mistake. But I don't touch the acromion before and now.
What is the future for this?
Future will be future will be reverse.
Bueno, pues este es el caso que más quería presentar. Creo que estamos así.
This is the case that I wanted to present. I think we're doing good in time. And at times, in your desire to do things well, we do not assess right the things that we have in front of our eyes.
Big manner could be great in the small tail of the part of the subscap. So if you're able to repair the subscap, if you want to reinforce one out, but you want to mimic the subscap, I think the lateral is still the best one.
Sí, para... Perfecto. Bueno, continuando ahora con fracturas, vamos a hablar sobre
To continue with fractures, we're going to talk about the role of the arthroscopy and fractures. I've been here all day long. So now we're going to talk about the role that arthroscopy can have in fractures. This is what I've been asked to present by the organizing committee. So this is my disclosure. Okay, so I have divided this into several points because Dr. Zurita is going to talk about the arthroscopic great tuberosity, and I'm going to talk about the lesions which take place in the instability, the glenohumeral lesions, and I'm going to ACR joint and the complications that we may experience. So this is what happens when you have this type of situations. Those who have done an arthroscopy, this is a catastrophe. When we have a dislocation like this, I wonder what would we do so we install we place a device and then we will wait to see what happens. This, to me, this is one of the indications, surgical indications to begin with, when we have a dislocation, because otherwise there will be a bone effect that is important that will have to be resolved with a non-anatomical effect. The images will be very important. The MRI is going to provide, the TAC is going to give us more information, and also the diagnosis of lesions associated that will provide, give rise to the final treatment. And in these fractures of the glenoid, I like to use the arthroscopy at least for the control of reduction, and oftentimes you can do the full treatment with an arthroscopy technique, like in this case with 2 screws, and you can do sutures as well. And in this case of the glenoid, it's extremely useful. The small defects, they can be treated with arthroscopy techniques in the anterior part and in the posterior part as well. As you can see there, this is acute bone, the repair of acute bone defects. Perhaps the most difficult thing is to get to an early diagnosis. And humeral heads, you're familiar with this. This is, if this were in a different, you would do an operation, you would lift the area that is affected, but the shoulder can tolerate pretty much everything. And I don't know if we're wrong in the future. The repair of the humeral bone defect will depend on the size, the direction, location, and so in the association. So I think that in the future we're going to have more indications of these type of lesions. And the same applies to the osteochondral lesions that we have in the rest of the section. Will define as well the future of these joint. For example, these are osteochondral lesions that we will be experiencing. This has been a problem. I think that with the new grafts, we see these less often. But there have been some years where we've seen fractures due to osteolysis, and that was an obsession in 2000. And in this case, as you can see in this image, there's a fracture line on the site where the grafts or the implants were located. Another topic has to do with the convulsion, and in this case, we can see a subsequent dislocation where the anterior part is normal, and then you see a rupture, and then there's a Hill-Sachs, a reverted Hill-Sachs, which can be seen through the arthroscopy, because if the addition is diagnosed very recently, you can obtain an outstanding outcome as long as the convulsive episode is controlled. And the anterior part, you can see that is easy compared to the posterior part, which is more frequent, but it's not easier. For younger people, this may go unnoticed. It still happens, not too common, but we may see it in patients that are unconscious, and we need to explore the external rotation block. Because the worst thing that can happen is to bring a patient to the surgery, doing an operation without reducing the dislocation, and that's a tragedy. and very difficult to explain. So in this case, it was treated with a plate, but the shoulder was dislocated. There is an intramedular, and the patient was subjected to a surgery. Absolutely useless because the shoulder it remained dislocated after several weeks. As to the fractures of the tuberosity, this is a surgery that I like a lot. You can only do sutures or screws, regardless of your preference. But to me, in my opinion, I think that this allows for mobility. And in the case that there's a displacement, and the treatment can actually be through arthroscopy. Now, in terms of the fractures, in these cases, this is not a distal fracture, but the implant that we have placed there is more harmful than benefit, and it is very difficult to know where they are anchored. Perhaps on the other side, there we had to do a reconstruction. We need to remember the primary stabilizers, which are statics, which have this type of acromioclavicular ligaments, because the objective in this case is to rebuild and to stabilize those lesions when we decide that they have to be surgically treated, which is not always the case. In this image, you can see what's the design of this complex ligament area of the shoulder, and what are the tools that we have in arthroscopy, which can actually help us a lot, and the treatment both at the distal fractures and at the level of the dislocation. These are different button systems. I'm not going to extend beyond in this session. And I would like to see a little bit, I would like to look at the complications. The arthroscopy is extremely useful, and the stiffness or rigidity is doing a capsular release. It is quite efficient. You can achieve mobility very close to the full mobility. But my life changed 10 years ago when I obtained the collaboration of an anesthetics, physiotherapy, and nursery, and because they place a catheter. This is a patient with an exploration, a pre-operational of exploration of a rigidity or stiffness that was quite severe, where we achieved this mobility. But for two, she had to put up 2 weeks with the catheter placed, and physiotherapy was done with anesthetic. So I think this is something that has changed the treatment of rigidity, in my opinion. We also have a pseudoarthrosis, which are, and this is something that I also like, but we need to explain to the patient that the post-operatory will be very long, because it is very similar to the reparation of the cuff. And then this is another case of this is the pseudoarthrosis of the scapula. This is an easy technique, but you have to be very careful because of the complications and risks that may be seen if you're not an expert. Thank you, Angel. Now we're going to have Dr. Zurita. He's going to talk about fractures, just like Angel. Dr. Zurita, the floor is yours. Good morning. In Spain, it's good afternoon. It's good afternoon when you. So today, I think I guess this is good morning here. So with this session, this is this is going to be the end on this side. So I want to express my gratitude again to those who organized the Slard event. Giuseppe for inviting me. It's been a pleasure and an honor, and I hope that you keep on inviting me, because if there is, I love coming to Colombia, which is something that I like most than speaking. So going into the topic, I was at how can you do a major tuberosity through arthroscopy? We're going to start. So we're going to be answering all the different questions that I'm formulating here. The first thing is that that these type of fractures represent 17 to 21% of the humeral fractures. They're always associated to a trauma, whether dislocation on the shoulder. For the diagnosis, the best option is a tag with the new presentations and 3D views. This allows us to have a 3D analysis that is quite accurate, and it reproduces the actual situation, and therefore this allows making decisions which could be more accurate. And when I decide that a surgery has to be done, like a regular fracture that we're normally treating in the anatomic region, because and the displacement of the fracture. So this is a bibliography or a literature analysis with the most common one. So we normally use 2 or 3 millimeters of separation to, and if we have any suspected fragmented ligature. The surgical technique, we begin with the anesthetics. We do a regional nerve block, and then we normally do IOT with general anesthetic. The position, you can use any of the 2 positions. In our case, we prefer the lateral decubitus. It is more comfortable. We have a good vision of the articular space. We have a better, and it is also comfortable when we want to use the radioscope. And something as easy as going or removing the radioscope depends on the position. And this also allows us to have a very good rotation of the shoulder when doing a reduction. The arthroscopy portables are typical for any cuff surgery. We normally include some accessory. We have it can be percutaneous for controlling reduction and the introduction of implants. This is going to depend on the preferences of each surgeon. Why should this be done through arthroscopy? Due to the reasons that we are all familiar with, which we have repeated, because we can determine which are the lesions associated with the tear, whether from the labrum, from the cuff, from biceps, from the and these are frequent situations in these type of fractures. We need to do a debridement of the bone fragments to facilitate reduction. You should not exceed or go beyond that, because when we have a small fragment, if we do a lot of debriding, we can end up having no support by the time we do the repair. This will make it hard to conduct osteosynthesis. The reduction can be done directly. We can do it directly with an intra-articular vision where we can see in the subacromial space. We We may have a radioscope if we have any doubts to control that control of reduction, and by maintaining the rotation of the shoulder, this will facilitate this process. In our case, it is actually useful to have the fragment once released. We can use a Kirchner needle and as a joystick. We don't have any joysticks anymore, but this is what we used to have in the past. But they're useful to move the fragment and to place them and to place it on the desired site. Osteosynthesis will depend on the size of the fragment. It has to be a generous space in a young patient. We can use cannulated screws, and oftentimes, although the fragment is not big, or the fact of maintaining the integrity or not desiccating this, it will be sufficient to maintain the screw that will reduce the fragment and will maintain the osteosynthesis. As indicated by Dr. Calvo, to suturing, if we have poor bone quality, we need to use implants. And how can we use it? We can use a simple roll, two roll, a bridged suture, and the one that could be easier for us. The type of implant is the one that we're most familiar with. In our case, we normally use Ngles to set we pass the thread through the handle, and we reduce the bone fragment, and then we anchor it on the side, on the lateral part, as a suture, as a knotless suture. But what happens with the extraction of material? This is something that I wanted to include because because removing a humeral plate where we have could actually have any type of advantages, but to do it through arthroscopy. In all of the fracture or tear cases, that they do not evolve and they may have any complications, because the prior analysis done through arthroscopy will allow us to discard if there are secondary lesions that may have been gone unnoticed in the osteosynthesis, or which may have taken place and which allow resolving this through arthroscopy. For the plates and humeral plates, we normally prefer the lateral. We use the percutaneous for the extension of the cephalic. Then through a mini open, we can remove the screws, and then we extract the plate. The treatment of this type of treatment has advantages because it is not too invasive, and this will translate into less morbidity. This can happen in any of the two positions because this allows the evaluation and treatment of lesions associated at that time. We can also have a very good control of the fracture reduction from the articular or from the subacromial place. The stabilization, we can select from screws or a suture with implants, and the mechanism is not different from the one that we normally do for the common cough tears. It is a reproducible technique. It does not require such an ample learning. Those having a minimum skills and who may have done this type of learning is perfectly trained to do it. Now, as to the extraction of material, in general term, it can be adequate when we have a poor clinical result of the primary synthesis. We know already the limitations that we have in this type of study within the elbow when doing the TAC. So I think that this is a very good option to discard the secondary options. And therefore, it does not involve such a huge problem, and and we do not record so many cases, and it does not allow the treatment of sequels. And at that time, for example, the rigidity of which is similar to a capsule. I am exhausted now, and I want to reiterate my gratitude for your attention. And again, thank you so much for the invitation, and I hope I can see you soon in Spain or here in Colombia. Thank you.
Charla. ¿Alguna pregunta?
Thank you, Nestor, for this excellent talk. Are there any questions?
Lo que nosotros hemos visto, sobre
We
todo en
have seen, especially in larger fragments, that we can combine it with the X-ray image because it's difficult to see the peripheral part. Do you do that as well? This is to facilitate the access of the radial to be able to reduce the type of fracture. Obviously, the image shows the entry of a screw, but sometimes we need more because the fragment is very wide. The truth is that what I haven't said before, which is something that we tend to use when we introduce the we feel bad about this later, but we can also use sutures on the lateral wall to create a kind of discharge of the tension of the supraspinatus, similar to when there is a lesion in the patellar tendon. Sorry, they're not using a microphone for the questions.
Sí, uno se queda, duerme mucho más tranquilo, desde luego. Muchas veces no
Yes, you can sleep far better. Sometimes we don't know what we've done, whether what we've done is good or bad, but if it helps us rest better, then it will always be good. Doctor, hello, good afternoon. In your experience, when do you manage a tuberosity fracture in a conservative way? If so, how much time do you supervise this for to understand whether it needs to be managed surgically? While conservatively, when there's no displacement in terms of 2 or 3 millimeters, no posterior translation, and we maintain it for 3 or 4, depending on the characteristics of the patient. The least physical requirements the patient has, the more conservative we are, and we perform strict surveillance of the entire orthopedic process. For the rotator cuff, if there's no displacement, there may be tomorrow. So we try to look at the evolution to see if that secondary displacement occurs. So we usually do suggest surgery in the future if this is needed. If there are no more questions, we can close this block. Thank you, Nestor. Thank you, Francis. Angel, Mario, thank you very much. Thank you, Giuseppe, for the invitation. We wish you much success. Thank you.
Me preguntó un doctor que de una práctica en línea y daban diploma, ¿no? Ah, lo bajan de la página. Ah, todos. No los crean físicamente.
Sí. Pausar.
Bueno, no, esperemos que sí, porque es una hora de receso.
Pasa que este año acá coincide con el de España. La primera semana coincide acá.
And this history of the patient is 31 males and repeated dislocated of the left shoulder for 10 years. And so up to now, the patient has been dislocated for more than 10 times. After the reduction, the shoulder joint has no